start the initial inauguration, Vishal?
Yes, yes. They are giving countdown.
Acha, let Amey sir join, Vishal. We'll start in front of him.
Yeah, let a message
Support
join.
Yes.
support team, please delay the countdown. We will tell you again.
Yeah. Sir is just logging in only.
Support team, please wait for 1 minute.
Sir, actually, we are live now, sir.
Okay, no
Okay.
problem.
Okay. It
Yeah.
is okay.
Madam, shall we start? Okay.
Amay
Uh,
sir is joining, no?
Amey sir
Yes.
is just logging in. So I thought if we
We
give,
wait, no problem, ma'am. We wait.
yes,
Yeah, yeah.
2 minutes. Amey sir has joined. Good evening, Amey sir.
Good evening, Monica.
Okay, Vishal, now we can start the program. Chief
Good
guest.
evening, Amay sir.
Good evening. Good evening.
Good evening, PK Shah sir.
हाँ जी गुड इवनिंग डॉक्टर रणदीप
Good evening, sir. नमस्कार
Yeah.
सर, नमस्कार. आपका आशीर्वाद सर.
अरे बस क्या ऑलवेज विथ यू
Yeah, yeah.
So, welcome to all faculties. And now our chief guest, sir, has joined. Dr. P.K. Shah is there to give his blessings. Let us start the program formally. Dr. Vishal Dave is our
Yes.
coordinator for the program.
Good evening. Good evening, everybody. Myself, Dr. Vishal Dave. I'm gynecologist and medical advisor to Intas Pharmaceuticals. I welcome you all on this Doctor's Day in the 33rd episode of Synergy with 44 AMOX and Foxy societies. The topic is ovulation induction, pulse, evidence-based approaches in IUI and IVF. Before starting the webinar, we will have a prayer.
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः.
It is my privilege to introduce Dr. Monica Singh. Dr. Monica Singh is President-elect of Bhopal OBGY Society. She is Founder-President of ISOP Chapter of Bhopal. She is National Executive Member of ESAR. She is Joint Secretary cum Joint Treasurer of MPIAG. She is Coordinator of Foxy Infinity Committee. She was also the convener of Perfection Series and Symbiosis Series and also the convener of present Synergy Academic Club. Over to Dr. Monica Singh.
Thank you, Dr. Vishal. And a very, very warm welcome from the Synergy Club to all dignitaries who are present and who are representing the great state of Maharashtra. I think it is Maha state, so it's called Maharashtra. I always get that feeling when I say that name. So today Synergy Club is proud to associate itself with 44 societies of EMOX in its 33rd episode. So we have arranged all the societies in alphabetical order uh, so that we start from Ahmednagar and go to Yavatmal. And today our live webinar, which is also going to be recorded on YouTube, will be dealing with the ovulation induction pearls and evidence-based approaches in IUI and IVF. We have been doing pretty complicated studies and topics in Synergy. So I recently got a feedback from some trainees and postgraduates and practitioners that let us do basic topics. So I thought ovulation induction is a topic which everyone wants to listen to, and especially if you've got speakers of national repute, the webinar becomes all the more meaningful. To take this program forward, I'll just walk you through the scientific program before we welcome our dignitaries. Dr. Vishal, can I have the scientific? So we will be dealing with as the chronological order of ART ovulation induction in IUI by Dr. Pratik Tambe, ICOG Secretary. We'll be dealing with controlled ovarian stimulation in IVF by Dr. Jatin Shah. And lastly, there will be a panel in which we'll be discussing the dilemmas in ovulation induction in IUI cycles. So this is our brief, concise, and very well curated program. And to start the program, we have to welcome and we warmly welcome Dr. Amey Purandare sir, our chief guest for today. Dr. Amey C. Purandare is President AMOX and Joint Treasurer of FOXI. We warmly welcome sir and we thank him for his time and his gracious presence in the program. He is consultant obstetrician and gynecologist at Purandare Hospital and KG Sumaya Medical College. Sir H.N. Reliance Bhatia, Masina and Mumbai Police Hospital. Sir has been Senior Vice President of AMOGS in 24 to 26. At present, he is President of AMOGS. He has held various important posts in FOXI. He's been the chairperson of Food, Drugs and Medical Surgical Equipment of FOXI in 2015 to 17. He was Joint Secretary of FOXI in 2019. Assistant Administrator of FOXI Manyata Project on Quality Care in Safe Childbirth, Clinical Secretary of MOGS and Mentor of Youth Council of MOGS, Member of Medical Advisory Panel FPAI and Finance Officer FPAI Mumbai, Peer Reviewer of Jogi, with several awards to his credit like A.E. Dastur Gold Medal, B.N. Purandare Gold Medal, Prince of Wales Gold Medal, Dr. C.G. Saraiya Gold Medal, Dr. Deena N. Patel Gold Medals, Mohanlal Desai Gold Medal, AMOGS Dr. R.H. Acharya Paper Prizes, Best Paper Prize, Dr. Kamal Jain Best Thesis Award, FOXI Dr. R.D. Pandit Prize for Best Thesis, MOGS Dr. C.G. Saraiya Traveling Fellowship.
Monica, I think we should concentrate on the webinar. Thank you so much.
And your awards are so many. Yesterday we had a dry run and we were just admiring the number of prizes. I think there's hardly any prize you have not received, sir. So, sir, we are blessed to have you. We are blessed to bond and be face to face with everyone belonging to AMOGS. And it's such an exciting and a great day for us, especially on 1st of July. Happy Doctor's Day to you, sir. And we are waiting for your address.
Thank you, Monica, for those kind words and the kind introduction. First of all, I wish each and everyone from the dignitaries, the faculty, and the delegates a happy Doctor's Day. I think it's a day that we get pampered a lot. Okay, everybody is wishing us the best. But I think not just celebration, but it is a day where we need to understand our responsibility and our role to our patients. I'm thankful to Monica for having invited me for this webinar series, this collaboration between Madhya Pradesh and Maharashtra. And I'm thankful to her for including all the societies of Maharashtra, because as you see that we are a union of close to 45 societies and close to 9,500 doctors. But what we need to understand is that this particular webinar is very correctly called as synergy. If you look at the term synergy, it means amplifying energy, but I have two different meanings to synergy. The first meaning is that it amplifies science with energy, and therefore it's called as synergy. So it's not just a collaboration, but it is also more importantly the amplification of science across states, etc. But more importantly, I was trying to understand why Monica called it synergy. And Monica is a very special person. I wish her all the best in her FOXI endeavors. And it very clearly tells you it is Singh's energy, and therefore it is synergy. Okay. So it is Monica Singh and Randir Singh's energy, therefore it's called as synergy. But more importantly, I think full credit to Monica for her perseverance, her dedication, her passion, her dedication towards women's health in general and infertility in particular. She will be definitely an asset to any organization that she works for, especially FOXI, because I've seen her closely working in the various academic forums. I also compliment her for the excellent curation of the program. As you can see, we have faculty Dr. Pratik Tambe and Dr. Jatin Shah, and also the practical based panel discussion on dilemmas in ovulation induction. Ovulation induction looks simple, but it's not. Each case is individualized, each case is challenging, and each case does every time. So we need to rethink, re-strategize, and go in every time. And I'm sure that the panel discussion will ensure that we get better insight and practical knowledge for the benefit of our patients. My special appreciation, acknowledgement, and pranam to all the Foxy and AMOG's dignitaries. I think it is because of the inspiration and the motivation that these luminaries give to us that we are able to work for organizations like Foxy. I can see Dr. P.K. Shah, Dr. Rajendra Singh Pardesi, Dr. Kiran Kurtakoti, and all the other seniors who have joined. I'm thankful to them for having motivated us in our journey in these professional organizations. Once again, I wish all of you a happy Doctors' Day. The Singhs have a lot of energy and therefore there is synergy for us. And I wish all the delegates maximize whatever knowledge that they get this evening and hope to see and learn more. So happy learning to all of you. I also see some of my other friends from AMOGS and Foxy, my good friend Dr. Girish Mane, Dr. Sujit Konkar, Dr. Vaishali Chavan, Dr. Supriya Arwari, Dr. Rajendra Singh, Dr. Rajendra Nagarkatti, Dr. Madan Kamble, Dr. Sharvari Jadhav, and a host lot of others who will join, as also Dr. Sharad Shinde. So I wish all of you the best in whatever you are planning. I'm sure all of you all are, I'm certain that all of you are real value additions to any organization that you work for. And I wish you all the best so that you can contribute more to these organizations. Thank you once again.
Thank you. Thank you so
Thank you,
much.
man. Thank you, man, sir.
And thank you for the personal words and blessings for us, sir. It really means a lot. And your address to AMOGS correctly proves that how much a great leader you are. You are all inclusive. You have included every faculty in your inaugural address, in your chief guest address. And that speaks volumes of the vision you have for AMOGS and your leadership qualities, sir. So all the best to you. And we thank you for your wishes and for your gracious presence. AMOGS is studied with stars and luminaries, as Amey sir rightly said. The blessings of Foxy past presidents are always with us. And the past president who's senior most and holds almost the respect of a father for me is Dr. P.K. Shah. Dr. P.K. Shah, sir, is past president of organizations like Foxy, IAGE, IFUMB, MOGS, AFTT, and he is the teacher of teachers. So many presidents of Foxy, like Dr. Jaideep Tang, they start their lectures and orations with reverence and a lot of respect to Dr. P.K. Shah and his teachings. We know what a bright luminary he is in the field of academics, his passion for teaching, his passion for ultrasound. Every conference you find him gracing the academic activities, cultural activities, his words of support, his words of blessings. And I have personally learned a lot from Sir. My vision of Foxy is so bright and so encouraging because of people like Dr. P.K. Shah, who present such a good impression about our organization to all the world. Sir, the stage is all yours. It will be very humble of me to read, all your slides. We want to listen to you, sir, and we thank you for your gracious presence.
Thank you so much, Monica, for inviting me. First of all, happy Doctors' Day to all the doctors. Number two, it is very difficult to get 8 past presidents together on one platform and many luminaries from Foxy and AMOGS together. So congratulations to you and Dr. Randir Singh for having such a mega event of 4 hours webinar which I have never heard of in my life. So we are all looking forward to this webinar, and very good topics which are going to be discussed by Dr. Pratik Tambe and Dr. Jatin Shah, and then followed by the panel. But what is important is that I have seen you for last 4 years working so hard in the area of infertility with different topics, different webinars, and I'm thoroughly impressed by the energy that you have. And as very rightly said by Dr. Ameya, that it is not sing plus energy is synergy. So that's something great. And I'm really happy to be here with you all. And without wasting time, I think I wish you all the very best for your chairperson's post that you're contesting for in this year. And hope to see you as chairperson of Infertility Committee in future. Thank you so much for inviting me, and all the very best for all your activities in future. Thanks a lot.
Thank you.
Thank you, sir.
Thank you so much, Dr. P.K. Shah, sir. And we'll be very happy if you could stay on in the program and
Yeah.
enjoy the academic activities. And
Thank you.
I also I think very many of our faculties and past presidents are traveling to Eshrei. As I speak, Eshrei is starting from tomorrow or day after. So many people are in transit, flying to London. I have personally talked and taken blessings from Dr. Suchitra N. Pandit Madam, Dr. Prakash Trivedi Sir, Dr. Rishma Pai Madam, Dr. Nandita Palshetkar Madam, Dr. Rishikesh Pai Sir, Dr. Jaideep Tang Sir, and Dr. Sunita Tandalwadkar Madam. They were very, very highly appreciative of this program. And maybe if we are lucky, they can join for some time in between. So now we have our guests of honor for today evening. And Dr. Rajendra Singh Pardesi Sir is with us. Sir is the past president of EMOX and a mentor and
It's okay, Monica. It's okay. Thank you.
Sir, we
Mm.
are with you in the moment of grief for the personal loss in the recent days, sir. And we appreciate your presence and we seek your blessings, sir.
Thank you. Good evening, everybody. Happy Doctors' Day to all. Respected Chief Guest, Dr. Ameya Purandare, my mentor and past President, FOXI, Dr. P.K. Shah, sir, and all guests of honors, Dr. Parag, Dr. Kiran, Dr. Niranjan, Dr. Parikshit, Dr. Meenu, Dr. Girija, Dr. Ajay Mane, Dr. Komal, Dr. Bella Bhatt, and all dignitaries and special guests and Maharashtra stars and friends. I wish to congratulate Dr. Monica Singh and Dr. Randhir Singh and program coordinators, Dr. Purva Barkur, Dr. Virul Srivastav, for organizing such a practical management webinar. You can say a mega event, 4 hours mega event on ovulation induction. And that program, we are very happy and energized in this synergy program with AMOX. With a galaxy of faculties like Dr. Pratik Tambe, Dr. Jatin Shah, Dr. Tarini Taneja, Dr. Monica Singh, and with chairpersons and our panelists, this is going to be a great event. I wish every success to this webinar. I will just, Dr. Ameya told that sings energy in synergy webinar. So I will also add my energy I just sing in this webinar. And I wish every success to Dr. Monica Singh for her future endeavor in FOXI, as she is contesting for the post of chairperson of Infertility Committee FOXI. And we are all with you. Thank you so much for inviting me. Jai Sri Ram.
Thank you, sir. Thank you, sir.
Thank you so much, sir. And next, our guest of honor is Dr. Parag Biniwale, sir. Is my audio better now, Dr. Vishal? Okay. So there was some problem with the settings. Thank you so much for your blessing, Dr. Rajendra Singh Pardesi, sir. Dr. Parag Biniwale, past ICOG chair, will be joining soon. So I will now welcome our guest of honor, Dr. Kiran Kurtukoti, sir. Sir is the past president of EMOX and a very vibrant figure and dignitary in the field of OBGY in Maharashtra and nationwide. Sir has got huge experience at
Thank
national
you, Dr.
scale and
Monica. Thank you.
organization.
Thank you. Namaste. Thank you, Monica. Hello, Ranjirji. Thank you so
Thank
much
you,
for
sir. Thank you,
inviting
sir.
me, for being the guest of honor. Thank you so much. And Dr. Monica, really, I've been managing everything on all the fronts is really very difficult. First of all, happy Doctor's Day to all of you. And Randhir and Monica ji, a happy 32nd wedding anniversary also to you. And to manage everything at family front, then your daughter is at the Bhopal Medical College, your alumnus Medical College. So managing that, managing your IVF practice, I think it takes a lot of efforts. So I think one day you should have one synergy series where both of you should say that how we manage our practice with our family, that is own family, huh? Not other family. So how we manage our own family and how we manage our practice, and plus manage the Foxy, ISAR, and all those things that you are doing at the time. So you are a all-rounder, both of you, Randirji and Monica. Although Randirji, please excuse me, we will be praising only Monica. So your
No,
turn
yes,
will
sir.
come
Yeah,
sometime
sure.
later, maybe.
Yeah,
Yeah,
sir.
yeah. So thank you, and I see a lot of faces. Rajendra Singh Pardesi sir, namaskar. Hi, Rajendra Nagarkatti. My appreciation and congratulations, Rajendra, for you being getting elected as as the VP of Foxy from Amok side. Thank you so much. Supriya, hello to you. Sharad, best wishes to you. And Dr. PK Shah, incidentally, for all of you, Pune Society has honored Dr. PK Shah sir to be an honorary member of Pune OBGYN Society. Sir has shifted to Pune, and Pune is honored by his presence. So thank you so much, PK Shah sir, for that. My friend Girish, I know you are in the line sometime or the other. I know you are in the queue. Madan, congratulations to you. I know you are in the car right now. So congratulations to you again. And my friend Vaishali is also in the pipeline in the queue. So sometimes we have to say something good for Vaishali also. And Supriya and everyone. So thank you so much, Monica ji. Really, 34th Synergy webinar. I mean, we just concluded our Amongst ABCDI program, and the enthusiasm for that program was so huge that I have shared this brochure with them also, so that our members, our delegates who have joined for that program will also be a part of this webinar. So thank you so much. And I'll sit throughout, even if you may or may not want me to sit, but I will sit throughout the webinar. But thank you so much. And really, your enthusiasm, or that the smile captures. जैसे Supriya का smile captures. Everyone takes them together. Is attracted, magnetic towards that smile. गिरीश भी देख रहा है, हंस रहा है. पीके शाह भी हंस रहे हैं, है ना? परदेशी सर भी हंस रहे हैं. That smile. It takes you. It binds everyone together. So I think same thing goes for you, Monica ji. And best wishes to you. Definitely go ahead. I don't see any reason why you should not be at the helm of whatever affairs in whatever organization that you choose to. So my best wishes to you also, and my best wishes to the program also. रणधीर जी, आपके लिए अच्छी बातें बाद में कभी तो.
Sure, sure, sir.
Thank you so much. Thank you so much, and my best wishes for both of you. Thank you so much.
Thank you, sir.
Thank you so
PK Shah
much.
sir, it was thank you for moving to Pune. Pune will be benefited highly by your again charming presence, charming smile, and your aura. Thank you so much, sir.
Thank you.
Thank you. What a great speaker Kiran sir is. I was just is measuring the speed of his sentences, sir. You can go to Guinness Book of World Records, sir, with the speed you speak, and you have not repeated a single word in any sentence, sir. So thank you for your blessing, sir. Thank you for your vibrant presence, your enthusiasm, and with the large heart with which you give the blessing, sir. Thank you so much. And today we are very, lucky also, sir. 1st of July, I thought when I was planning the program with Synergy team, I thought 1st of July will be full of webinars. But whether, the fact is today, ours is the only webinar on 1st of July. The rest, all the webinars are after 2nd July. So we were lucky we could get all of you, and we wanted each one of you. So thank you, Kiran sir. And we also thank Dr. Niranjan Chavan sir, the treasurer Foxy, a very senior leader of Foxy and a great mentor and support. Sir is in transit to UK along with Komal madam. We thank them. Dr. Parikshit Tang sir is already in UK with, I think, Dr. Jaideep Tang sir. I could not connect with Parikshit sir, though I tried many times. Dr. Meenu Agarwal madam and Dr. Girja Wag madam have extended their blessings to us. And Dr. Ajay Mane sir was also Dr. Purva. Can you please place a call to Dr. Ajay Mane sir if he is free? And yes, Dr. Bela Bhatt madam just lost her father on 27th of June, so she is there with her family. We extend all our deepest condolences to madam. She was very attached to her father, who was 92 years old. And now we welcome and thank our stars of Maharashtra. Stars of Maharashtra are the dignitaries, the luminaries who are going to illuminate Maharashtra and the whole of Foxy with their knowledge, wisdom, with their leadership. This is Dr. Madhuri Patel for us, President-elect Foxy. Dr. Suvarna Khaditkal, Madam Secretary General Foxy, who is leading the organization of 49,000 gynecologists from the front foot. Dr. Rohan Palshetkar, the very dynamic and brilliant Secretary General of AMOX, Chairperson of Foxy YTP Committee. We thank Rohan for all his support. And now we thank our Foxy Committee chairs. We have a lot of Foxy Committee chairs from Maharashtra, and all of them are fortunately very good friends of mine. Dr. Chaitanya Ganpule sir has always been very good advisor to me. He's chairperson of Foxy Endocrinology Committee. Dr. Alka Kuthe ma'am, also a very wise and mature person, always a word of good advice from her whenever I talk to her. She's leading the chairperson Foxy MTP Committee. Dr. Supriya Arvari rightly said the laughter of Foxy, the life of Foxy. She is chairperson of Foxy Adolescent Health Committee, and whenever we have a topic which is related to adolescent health, the first name which comes to our mind is Dr. Supriya. Dr. Sujit Konkar, a great friend, a chairperson, Foxy Genetics and Fetal Medicine Committee, always busy with the ultrasound machine. Otherwise, he's singing or playing cricket. Dr. Monica Umbardan, chairperson of Foxy Public Awareness Committee. And my God, she is aware of every topic you name under the sun. Her PPTs are brilliant and she's very hardworking gynecologist. We thank all of them. And now I would like to ask Dr. Sujit Konkar is there and Dr. Supriya Arvari are there. Please, can you say something about our program, your vision about your committee, your vision about Foxy, and whatever you want to say. Supriya, madam.
I think our seniors have given their blessings. There is not much to add, but just congratulations to you for conducting this webinar. Ably, aided by Randhir Bhaiya. He is always there as your backbone. And my greetings to all the seniors that I can see here. एक special खाली शायरी Doctors Day के लिए और फिर आपको hand over करती हूँ. Dedicated to all my dear doctor friends. कि आपको आपके हाथों में जीवन की डोर है, ले चले हैं सबको स्वास्थ्य की ओर है, आपके बगैर सबकी सेहत है जीरो, क्योंकि आप ही सब है असली जीवन के हीरो. Happy Doctors Day to all of you, and please continue the good work. And Monica, we are all there with you, no doubt about that. You are doing great work. Thank you so much. I seek blessings from Pardesi sir, from PK Shah sir, from Kiran, from I can see Parag has not yet joined, Kiran Kurtakoti, Ameya, all of you, all seniors and my contemporaries. Hi Girish, Sujit, and wish you all a very happy Doctors Day. Over to you, Monica. Thank you.
Thank you, Dr. Supriya, for always being very supporting and very encouraging for all activities related to academics, cultural, everything. Thank you. Thank you so much. We also thank our special guests from Jogi who are actually not there in the program because of the busy schedule, but we thank Dr. Sujata Dalvi, Dr. Arun Nayak, Dr. Anahita Chauhan, Dr. Ashwini Gandhi, Dr. Pradnya Changede, and Dr. Sushil Chawla, all luminaries from Maharashtra and heading Jogi in a very effective and meticulous manner. We also welcome and invite our special guests for the evening. We congratulate Dr. Kalyan Barmade sir and Dr. Rajendra Nagarkatti sir for being the VP elect from Foxy West Zone. And Dr. Rajendra sir is there right from the beginning. Rajendra sir, we would like to have a few words from you. Dr. Rajendra Nagarkatti sir, are you there?
I think he has
Actually,
logged
I have
out.
just come into the no, I have just come to the labor
Oh,
room
hi,
just now.
Raju.
So
Yeah.
I'm sorry. Hi.
Okay,
So there's a delivery happening. So
sir.
I'll just connect in some time.
Okay, sir. So thank you, sir. The best
Thank
thing,
you.
Yeah,
best
best
place,
wishes for Doctor's Day delivery, sir. Yeah.
best,
Yes. Thank you, sir. Thank you. Thank you. Best wishes to Monica. And
Yes.
thank you for the kind invitation. It's a wonderful program. And we've heard all the stalwarts. So thank you so much.
thank you, sir. And now I welcome Dr. Girish Mane, sir. Sir is past chairperson of Foxy and a very, very dear friend and senior. Girish, sir, a few words of blessings from you, please.
First of all, thank you very much.
Sir, audio is
Girish, sir, your audio is breaking. Yeah.
so we will wait for Girish sir to join. I think we have got Vaishali madam with us. Dr. Vaishali Chavan ma'am, can you please extend your blessings for the program? Dr. Vaishali ma'am? She was there. Okay, we will wait for her. And now I have the pleasant duty of thanking my co-convener, Dr. Randhir Singh, my coordinators, Dr. Purva Bhatkur and Dr. Virul Srivastav, who have been contacting you since we started, visualizing and designing this program. And thank you, Purva. Thank you, Virul. And Dr. Girish, sir, have you joined? Yes, sir.
Yeah. Sorry,
Yes.
actually, yeah.
Yes. Waiting
There
for you, sir. Yes, sir.
some issue
Well, Girish,
in
sir.
joining.
Yeah.
I think rainy weather, all the
Dr.
network.
Monica,
Yes,
yeah,
sir.
let me just wish everyone. I can see Dr. Rajendra Singh Pardesi sir, Dr. Amaya Purandare sir, and all the other luminaries, Dr. Kiran Koti, and my dear friend Dr. Girish Mane, Dr. Supriya Arwari, and others. So sorry.
I think because of monsoon, maybe the network is causing problems everywhere.
Yes.
Yes, sir. Thank you, Rajendra sir. Thank you so much. Girish sir, are you able to join?
Wish you the very best, Dr. Monica, in your endeavors. And as both Dr. Amaya and Dr. Rajendra Singh Pardesi said, Maharashtra is with you. So definitely you will have a fruitful outcome, and we wish you for that. And you are really, really doing wonderful work. So we really want to see you there. So thank you so much for the kind invitation. And I'll now hand it over to Dr. Girish Mane. Thank you.
Thank you. Thank you so much, Rajendra sir. You are in the labor room, yet you could speak to us and give us your blessing. So thank you so much and wish you a very, very successful tenure ahead as Vice President Foxy. And now I have the very, very pleasant.
Thank you so much.
Thank you, sir. Thank you so much. Girish sir, are you there? I think we will wait for Girish sir. Now I have the very pleasant duty. See, this program is made up of all the president secretaries whom I have personally tried and invited each one of them personally. So though it was, I had to do several attempts to connect with 88 president secretaries, but yet I find it very fulfilling that in the process of inviting them, talking to them, I have made so many friends. And I give my thanks to Dr. Madan Kamble and Dr. Sharat Shinde. If they had not provided me with contacts and photographs, the flyer would have taken a very long time to complete because most of the dignitaries were so busy that I could not connect with them offhand. So thank you, Dr. Shinde. Thank you, Dr. Madan. I welcome amongst us the Ahmednagar OBGY Society, President Dr. Renuka Pathak Madam and Secretary Dr. Neelam Bagal. Welcome. I welcome from Akluj OBGY Society, President Dr. Madan Krishna Kamble. We congratulate him for being elected unopposed to Foxy Sexual Medicine Committee. Secretary Dr. Amit Chopade. Next, we welcome from Akola, our dynamic laparoscopic surgeon, Dr. Rajesh Modi sir as president and Ankush Ajmera as secretary. We welcome from Amravati Society, Dr. Shalaka Bari, president, and secretary Dr. Sayali Jahagirdar, who conducted a very brilliant program of West Zone Yuva Foxy recently on 2021 June. We welcome from Aurangabad Society, Dr. Vinayak Khedkar, President, and Secretary Dr. Renuka Alsi Loya. We welcome from Baramati Society, Dr. Mrinalini Jalak, President, and Secretary Dr. Tushar Gadade. From Bid OBGY Society, we have Dr. Shalini Karad as President and our own Secretary, my good friend Dr. Sharad Shinde. And I would like to Dr. Sharad Shinde to please speak a few words and put his appeal for elections. Dr. Sharad, you can unmute.
Thank you, Monica Madam, given this opportunity to this such a great program of synergy, and I will appreciate your energy, such a sings energy. All of you say such a great thing. How will you manage this time? I will such a wonder how you will manage such all the things. I will request all of you. I am also a candidate for the chairperson of Ethics and Medical Legal Committee. Please vote for me and support. This election is in August and voting is from 16 to 25th August. So please support both of us. That is the request from my side to all. Thank you.
Thank you, Dr. Sharad Shinde, and thank you for your appeal. And we now thank our dignitaries from Bhandara OBGY Society. We have got President Dr. Bharat Lanjewar sir and Secretary Dr. Manoj Agalve. From Buldana OBGY Society, we have got President Dr. GB Rathod sir and Secretary Dr. Kritika Hire. From Chalisgaon Society, we have got President Dr. Narendra Chope sir and Secretary Dr. Sachin Khedkar. From Chandrapur OBGY Society, we have got President Dr. Shalaka Mamidwar and Secretary Dr. Monica Kotpalliwar. From Deoli Savangi OBGY Society, we've got President Dr. Sandhya Pajai and Secretary Dr. Aishwarya Bidkar. Aishwarya is also a panelist in our program. From Dhule OBGY Society, we have got President Dr. Jitendra Ghumare and Secretary Dr. Vishal Patil. From Gondia OBGY Society, we've got President Dr. Ritu Jain and Secretary Dr. Yogesh Sonare. From Gadeglach OBGY Society, we've got President Dr. Pratibha Chavan and Secretary Dr. Supriya Rudrab Gol. And I think 15 societies are over. We start after introducing our 15 societies. We will wait for the introduction of the rest of the 29 societies after the first talk. So without wasting any time, it is already 5:45. And this was the time anticipated to introduce all our dignitaries and take their blessings. And now I request my able coordinator, Dr. Purva Bhatkur, to start session 1. Thank you so much.
Thank you, ma'am. Now, moving to our first academic session, that is on ovulation induction in IUI. We welcome Chairperson Dr. Amit Chopade sir. Sir is presently Secretary of Akluj OBGY Society. We welcome you, sir. We welcome Dr. Madan Kamble sir. Sir is presently President of Akluj OBGY Society. Also, he is Zonal Coordinator of AMOX, Chairperson AMOX Sexual Medicine Committee. We welcome you, sir. We have with us Dr. Manisha Jagtap Madam. Madam is presently President of Nashik OBGY Society. We welcome you, ma'am. We have with us Dr. Manishe Janardhan Nagaonkar, sir. Sir is presently President of Kolhapur OBGY Society. We welcome you, sir. We have with us Dr. Nupur Kushal Mittal Madam. Madam is presently Secretary of Thane OBGY Society. We welcome you. We have with us Dr. Sachin Pawar sir. Sir is presently Secretary of Pandharpur OBGY Society. We welcome you, sir. We have with us Dr. Shailesh Kore sir. Sir is presently President of Mumbai OBGY Society. We welcome you, sir. We have with us Dr. Shalaka Bari Madam. Madam is presently President of Amravati OBGY Society. We welcome you, ma'am. We have with us Dr. Shamita Birmole Madam. Madam is presently Secretary of Sindhu Durganagri OBGY Society and also IVF Specialist. We welcome you, ma'am. We have with us Dr. Sarvari Jatav Madam. Madam is presently President of Miraj OBGY Society. We welcome you, ma'am. We have with us Dr. Vishwas Parulke sir. Sir is presently Secretary of Navi Mumbai OBGY Society. We welcome you, sir. Now I hand over the session to our chairperson to introduce our speaker, Dr. Pratik Tambe sir.
Dr. Sharvari ma'am, would you do the honors? Madam, please unmute. Sharvari ma'am, please unmute.
Good evening, everybody, and happy Doctors' Day to all the guests and the delegates and the speakers. I'd like to introduce Dr. Pratik Tambe, sir. He is the ART consultant and gynec endoscopic surgeon, Ashirwad IVF Center, International Diploma in Advanced Laparoscopic Surgery from France, then trained in assisted reproduction in Belgium, trained in clinical embryology and ICSI at London and Singapore, Governing Council member, Indian College of Obstetrician and Gynecology, ICOG 2021 to 2025. Governing Council member, Indian College of Reproductive Medicine, ICRM 2024 to 26. Patron and Managing Council member, Mumbai OBGY Society 2013 onwards. Managing Committee member, Indian Society for Assisted Reproduction, ISR 2020 to 2026. Past chairperson of Foxy Endocrinology Committee 2017 to 19. Past chairperson of AMOX Endocrinology Committee 2022 to 2024. Recipient of 31 AMOX and AMOX ISAR and Foxy prizes and awards. Editor of 26 books, 4 Foxy focuses and handbooks, 11 key practice points. Contributed 100 plus chapters, invited faculty for more than 1,000 events and organized 800 plus CMEs. Convener case ICOG Reproductive Medicine course 2021 to 24. Peer reviewer, Journal of Obstetrics and Gynecology of India, Jogi 2012 onwards. I welcome Dr. Pratik Tambe sir to start his lecture. Thank you, Monica madam, for giving me this opportunity. And I also thank everybody present on the for the webinar.
Thank you so much, Sharvari ma'am, for being there. Thank you so much for the kind introduction.
So good evening, everybody. I'm Dr. Pratik Tambe, and let me begin by expressing my gratitude to Dr. Monica Singh for giving me the opportunity to speak to you, a particularly boring topic, which I hope I'll try and make interesting over the next half an hour.
Pratik, your voice is not clear.
Monica has worked very hard in the field of
Vishal, we are not having the correct audio.
This IVF or advanced stimulation routinely, you're going to find this entire presentation a big crashing bore. So I strongly recommend you switch off your audio video. You please go and watch the latest Netflix drama. Otherwise, you're going to get bored out of yourself. If, on the other hand, you are a student, you're a trainee, you want to learn reproductive medicine, you are a general gynecologist who does IUI and still finding the initial steps a little difficult and daunting, then maybe this particular talk is for you. Success is getting what you want. Happiness is wanting what you get. Unfortunately, as we know, to mix metaphors, east is east and west is west. Sometimes the twain don't meet. I've structured this presentation in the following way. We start by talking about IUI and whether IUI as a methodology of treatment is now perhaps outdated in 2026 because IVF is so easily available and IVF is something which is pushed in a very big way by multiple different sectors, including the gonadotropin companies, corporates, and so on and so forth. That's a different discussion part. Let's talk a little bit about the cycle optimization. Then we talk about how we can enhance our success rates. What are the realistic chances of achieving success, that is pregnancy, with an IUI cycle? The utility of gonadotropins, what protocols can we use in day-to-day clinical practice, which are easy to understand, easy to learn, don't have a steep learning curve, and most importantly, come with good safety and efficacy as far as therapeutics is concerned. And most importantly, I feel one should also realize that there is a finite limit beyond which IUI is not encouraged or promoted. And we have to learn to say enough is enough. So having said that, now let's get started. The most important question of the day is whether we should actually be doing IUI. See, compared to when I started practice 25 plus years, at that point, IVF was something which was a little bit like black magic. It wasn't really something which was available widely. There weren't too many centers offering IVF. The costs were prohibitive. Gonadotropins were not easily available. In fact, Indian gonadotropin companies had just come into the market 25 years back. And on the whole, it was not a very favorable scenario for the practitioner. So most of us used to be general gynecologists, we used to do IUIs, we used to do timed intercourse, planned relation cycles, so forth. Today, the situation is still very different. As I said, 25, 30 years ago, there was a complete difference in opinion, not only amongst us clinicians, but also in patients. They used to see two different sets of consultants. One set was a general gynecologist, was very approachable. They were sometimes very busy with doing labor, delivery process, parents, etc. And getting time with them was not very easy, but we could be easily approached and one-to-one conversation was possible. And of course, in those days, we used to restrict our practice to IUI. On the other hand, the fertility consultants, fertility physicians, reproductive endocrinologists, or IVF specialists, call them what you will. Today, they are called as level 2 clinicians. They would obviously charge more. They would sit in posh air conditioned clinics. They often didn't have all that many patients. And of course, since they were IVF specialists, they used to promote IVF in a big way, which sometimes was beyond the financial capabilities of most of these couples. Therefore, they used to always think that IVF specialists को IVF ही करेंगे, उनके पास नहीं जाना है. That is something which you do as a last resort. More pertinent to today's discussion, we need to be realistic about what are the average success rates with IUI in the modern context and give patients a realistic, how can I say, idea of what the success rates are. And for this, we have this wonderful Cochrane meta-analysis, which is something we will see quite frequently during the remainder of this presentation. This looks at IUI in subfertile couples, and after assessing nearly 160,000 cycles, both partner sperm as well as donor sperm IUI cycles, they found that the live birth rates for partner sperm were approximately 8.5%. And for donor insemination cycles, they were a little higher at 12.4%, which means thereby that in more than 90% of cycles with partner sperm, the IUI cycles actually are not leading to clinical pregnancy. Now, off the bat, if you were to counsel a couple and tell them that I'm offering you this treatment and it has a 90% chance of failure. Clearly, the couple is going to think this doctor is of his doctor. He's completely stark raving mad. He doesn't know what he's talking about because there are clinics and there are newspaper advertisements which say 50%, 60%, 70% success rates with IUI. So, which world is this doctor living in? Maybe he's grown too senile. He doesn't know what he's talking about. And for those people, I have this slide, which is a very old slide from my annual report. And I should tell you, this is what tolerance is. This is not what I say. And if you do sufficient number of cycles for a long enough time, whether you like it or not, fortunately or unfortunately, the law of averages does catch up. You'll see that the clinical pregnancy rates are only about 15% in the best of hands, and the multiple pregnancy rates are about 6%. This obviously brings into question, how can we optimize our IUI cycles? How can we increase our success rates? And what are the tricks of the trade which you can use in daily clinical practice without being too cumbersome or bothersome to try and ensure that you get consistent success rates? One of the easiest ways in which you can improve your clinical pregnancy rates is obviously to have multifollicular development, because more follicles by conventional wisdom means better chances of fertilization and, of course, implantation. But more to the point, and what is the focus of today's presentation, is that just getting more follicles isn't enough, because as we know, multifollicular development can lead to multiple pregnancy. Multiple pregnancy carries its own issues, miscarriages, preterm births, NICU admissions, complicated deliveries, instrumental deliveries, cesarean section. The entire gamut of problems, and we are not even talking about the medical complications that occur during pregnancy, like hypertensive disorders, like gestational diabetes. All of those carry their own morbidity and issues for both the mother and the child. More to the point, I feel we need to have better quality oocytes. We need to have better quality gametes. And one of the easiest ways in which you can improve the oocyte quality is to actually prescribe gonadotropins. And this is published literature. This is a slightly old paper in 2015, which shows that if you add gonadotropins to your IUI cycles, then both your clinical pregnancy rate as well as your live birth increases significantly. In fact, if you were to do a plain clomiphene or a plain letrozole cycle, your success rate should probably be somewhere around 10%, 15% in the best of hands. These are figures from Western literature. In India, these figures are not achievable. You will see success rates significantly lower than what you see in this table. But since this is the published literature, I'm showing you this table. I don't have equivalent figures from Indian literature, but I can strongly assure you that you will reach nowhere close to these theoretical maximums which are published from Western countries. Therefore, it becomes imperative for us to understand whether there is clear evidence of benefit. And as always, we again turn to Cochrane meta-analysis. This is published in 2020, and this looks at meta-analysis of 15 trials of more than 2,000 women. And they conclude by saying that treatment with IUI in a stimulated cycle probably gives higher cumulative live births compared to unstimulated cycles or natural cycles. I don't know if anybody is doing unstimulated IUIs anymore in today's world, but this is something which is, I can say, bad in Western countries, where they want to use either minimal stimulation or they want to use only oral ovulations. They want to stay as far away from gonadotropins as possible. What we say that wheel comes full circle, and they want to avoid gonadotropins. But here the evidence clearly says that stimulated IUIs clearly gives you better cumulative live births and also results in shorter time to pregnancy as compared to what is called as the wait and watch approach. For unexplained infertility, one of the methodologies of treatment is supposed to be wait and watch or watchful expectancy, and that approach has now been rescued in favor of better management protocols which advocate early stimulation, especially with fertility. There is more recent evidence also that 90% of women are going to conceive with IUI, who are going to conceive eventually with IUI within the first 2 cycles, and 98% within the first 3 cycles. And therefore, the old days where you used to do 3-4 cycles, 6 cycles, 9, 12. In fact, just off the top of my head, I remember a patient who came to me almost 15 years back. And when I went through all her files, in various different clinics, she had undergone, you won't believe, about 25 IUI cycles. Now, hats off to them for the amount of money they spent, the patience, the mental trauma that they went through, and emotional upheavals that they and their families, of course, must have suffered to undergo 25 IUI cycles. The only question I had to ask them was, did nobody advise you IVF? And then the cat was out of the bag. Every clinic which advised them IVF because they had already undergone too many IUI cycles, they simply went to another clinic because they didn't want to do IVF. They just wanted to keep doing IUI. And that is how they ended up doing 25 IUI cycles. I think it must be something like a Limca Book of Records or a Guinness Book of Records. I refused doing IUI in that couple for obvious reasons. And I never saw them again. But I still remember that couple. We must also remember that IUI as a modality of treatment, since it has poor success rates, we must offer them a certain subset of population where you are going to have better chances of success. And these include young couples, shorter duration of infertility, those who have maybe anovulatory infertility or a mild male factor. Social issues like unconsummated marriage is still quite common in today's world. Couples are coming out more frequently with the history. In the old days, there was a lot of shame and stigma attached to it. So you wouldn't see these couples earlier on during their, how can I say, journey, but now more and more couples are coming forward. Also, there are several couples who don't live in the same, how can I say, physical location. The husband may be in London and wife may be here in India. Or maybe they're doing shift duties and maybe they only meet once in a month. So in these couples and of course in extreme infertility, IUI seems to offer a good option as far as pregnancy is concerned. In the same fashion, we must also examine certain couples where we couldn't offer IUI, and these couples are good candidates for therapy. Poor and hyper responders for obvious reasons. Hyper responders because you are afraid that they will explode. Poor responders because we know that the number of oocytes is less and the quality is poor, and therefore you would probably fast track them to ART. Patients who have multiple factors, endometriosis in advanced stage, multiple factor for obvious reasons, and again, patients who have severe or moderate oligoastheniospermia, and patients who have high DFI, high teratogospermia, all of these patients are good candidates for early referral to ART. Probably don't try more than 1 or 2 cycles in these couples with good counseling and warning them upfront that there is a poor prognosis. We also need to be able to evaluate before we start the treatment cycle as to what are the factors which are in favor of success in this particular couple who is sitting across the treatment from. And for this, I have an excellent paper which was published recently in 2023 February. And this looks at fertility predictors in women who are undergoing IUI. Obviously, the age of the woman, the biological age and the ovarian age are of paramount importance, and by ovarian age, I mean MH. The duration of infertility, shorter the better. Number of IUI cycles, as we said, the first 2 or 3 cycles maximum are going to give you the best results. If you have multifollicular development up to a certain point, chances are better. If you have good morphology of the endometrium, trilaminar or pentalaminar pattern, called on ultrasound, with good subendometrial blood flow, these women will likely conceive much quicker with their IUI cycles. Volume, concentration, that's the total motile sperm count, and I'll come to that in just one more slides. The etiology of infertility, absence of multiple factors, and finally the utility of gonadotropins, which is going to form the latch from this point onwards. This is an interesting paper from the Asian Journal of Andrology published in 2020, and this looks at only donor sperm, and it looks at the total motile sperm count, which is inseminated using donor sperm, and the influence of this on pregnancy and live birth. The reason why they've taken donor sperm is because these are donors who have already fathered children earlier, and we know that there is no male factor. So whatever result would be independent of the male factor and is purely based on the female partner's issues. And they have a lot of good data and good statistical analysis. They had more than 1,000 patients in this particular study. And they found that if you have a total motile sperm count, which is more than 1 million at the end of your insemination, then both your cumulative pregnancy rates and your live birth rates are significantly higher. Therefore, your EMSC is important and it is not to be taken lightly. Always calculate that, make a note of it, and in the discharge notes, make sure that the embryologist has. We now come to the large chunk of today's discussion. And what is the best stimulation to use during IUI cycles? And I will be honest and say that unfortunately, there is no one size fits all. There is no one standard protocol that you can use everywhere, all the time, for all couples. But having said that, there is one protocol that I have used for more than 20 years, which is applicable to more than 90% of most treatment-naive patients who don't have multiple failures, who don't have multiple factors. And if they have multiple failures and multiple factors, in which ways you shouldn't be recommended. This is the most recent human reproduction update published in 2020. And this looks at for unexplained infertility. And there were more than 5,000 women in 26 studies, which they looked at. And they found that when you administered gonadotropins as compared to clonidine, the clinical pregnancy rates were approximately 39% higher, which is a huge advantage. And we already covered this earlier. This is just a reinforcement of that concept that gonadotropin stimulators are the way to go, not necessarily because they induce multiple development, but because they give you better quality oocytes, and they also induce a lot of changes in the endometrium at the molecular and the genetic level, which makes endometrial receptor much better. We'll come to that in just a moment. And when you compare IUI with gonadotropins with natural cycle IUI, again, gonadotropin IUI is about 46% better. So the old argument in favor of lesser stimulation, mild stimulation, no stimulation, natural cycle IUI should be thrown out of the window because we are now in 2026 and it is incumbent on us as clinicians and professionals to give results in the shortest time possible. The old days when patients used to come to me for years together, patience, faith, they are over. Today, I'm lucky if a patient comes to me for a second or a third cycle. Most patients in major metro cities do not come to me. So this is the ASHRAE guideline on unexplained infertility published in August of 2023, and this is the summary article in Human Reproduction, again published at the same time. All of these references are freely available on the internet. They are not hidden behind a paywall. You don't have to pay $200 just to download one of them. You can freely find them. The DOIs are listed in all my slides, and if you can't find them, write to me. I will share them with you. How do you actually run a treatment cycle? This is something which is the meat and bones of nitty-gritty, the boring part of actually running. And this doesn't get enough attention, in my honest opinion, because you find that we do IUIs in thousands. And after a certain point of time, we get bored, we get tired of seeing the same things again and again. So we outsource it, we send it to a clinic clinician or a postposter or even a nursing staff. In some clinics, you have, if it's an IVF clinic, you have a dedicated counselor. But many clinics, especially someone who's a level 1 clinician, may not have a dedicated counselor. So then it gets outsourced to somebody like a receptionist or a paramedical staff and so on. This is vital, and this is where the gotchas happen. Folic acid and micronutrients is something which we all take for granted. I have seen several couples who have come to me and they have not taken folic acid in the past 3 months and they've already undergone the IVF. And they get very surprised when I tell them that now during your IVF cycle, you take folic acid. Let's not get into it. Tubal patency testing is something which has been drilled into our brains that you need to demonstrate tubal patency before you run an IUI cycle, because the worst thing that could happen is if she has blocked tubes, he lands up with an ectopic pregnancy. Rubella immunization status is probably more relevant for Western countries because most of our women are immunized, but at least it needs to be documented on paper that the IgG is positive. I see many couples who have undergone IUIs elsewhere where the male partner has not been investigated at all. There is no male partner infection screen. He directly comes on the day of the IUI, gives a semen sample, and Before that, even semen analysis or testing is not done because he's never shown up to the test. He never thought it was a couple's problem, like we always say. Lifestyle modification, you can see this slide lists all the important take-home messages for couples when you are starting the treatment. Ideally, you need to enforce these for at least 3 months before you run a treatment cycle. In an exact world, in a perfect world, in an ideal cycle, we would like to do that, but we don't have the luxury of time and choice in the most modern clinics. Ovulation tracking and fast track, all that we are going to cover very soon. So when you counsel your couples, you're going to talk about what is the indicator, protocol that you use, the financial issues and the repercussions. We're going to talk a little bit about semen freezing. If the male partner has issues with producing a sample, always have a backup semen sample. Infection screening of both partners needs to be there on paper, filed off, and there are many clinics which don't ensure this. So please, for heaven's sake, make sure that this is there on paper. You need to inform the male partner well in
I think your voice is not audible.
It is a recorded session. It is a recorded session. We'll tell the studio.
Okay, yeah.
Vishal, please tell the support team.
Yes, ma'am.
Support, the video is stopped.
Recording stop करना है मैम?
No. We cannot hear.
Continue.
The video has stopped playing. Support.
1 minute, ma'am.
Dr. Vishal?
Yes, ma'am. Support team here, ma'am. Tell me.
Yeah, the video stopped suddenly.
Whose video, ma'am?
The session which was going on, session 1.
Ma'am, I think the one who was presenting has been left. They just got out of.
No, it is a
It's recorded.
recorded video. Dr. Vishal, where are you?
Ma'am, who was sharing that? Dr. Vishal?
Dr. Vishal was sharing it, and he's
Okay.
also not.
I guess, ma'am, Dr. Vishal has got disconnected from the meeting. Just allow me 1 minute. I'll just give him a call. Just give me 1 minute.
Yes, please. Welcome, Jatin sir. Good evening. Welcome, Parag sir. Namaskar, sir.
Welcome, sir. Welcome, Jatin sir. Welcome, Parag sir.
Hi, Monica. I'm sorry. I thought it was at 6 o'clock, so I waited for 6 o'clock to
No problem, sir.
start the webinar. But very interesting session going on, and I think the ace is yet to come. So, Jatin, we are looking forward to your session. And Jatin, in fact, is one of our own very, very favorite persons. Last year, the Pune OBGYN Society had invited him for a solo performance, and from 9 to 5, he kept our members engaged, and they were extremely happy with the deliberations. Monica, I must appreciate your efforts. 33rd program is not easy. Spending that much time talking to the faculty and thinking of topics, that is something which is really amazing. My best wishes to you for your forthcoming election, and of course for your tenure as the president of the Bhopal OBGYN Society. In fact, all of us are looking forward to visiting Bhopal again during your tenure. Thank you very much for the invite.
Yes.
Thank you, Parag sir. It was really nice of you to join. I mean, I forgot to call you, sir. I had some network issues, so I could not call a few people before the program started.
And I'm happy to see the new PG student, that is Randir,
Yes, sir.
attending the program.
Yes, sir.
Vishal, why has the video stopped, Vishal?
Madam, were you able to see the video? Because I got a phone call that they are not able to see the video, so I stopped and again resharing.
Yeah. Okay, resharing from that place. Yeah.
Video stopped at the point when Pratik Tambe sir was talking about counseling of the IUI patient. We will tell you about the slide, okay? The point, please start the video at the point when 18 minutes of the talk are left.
Okay. So I am again starting at 18 minutes, ma'am.
18 minutes are left.
Yes, ma'am.
18 minutes left, yeah.
It's a
Yes.
38 minutes talk. Please start at 20 minutes.
Yes. So just only I got the feedback that it is not safe, so I stopped the video actually.
We thought you have gone for a cup of tea.
No, ma'am.
several couples who have come to me and they have not taken folic acid in the past 3 months.
Now,
They've already
ma'am,
undergone PRP.
Yes, yes, that's okay.
And they get very surprised when I tell them that now during your IVF cycle, you need to take folic acid. Let's not get into it. Tubal patency testing is something which has been drilled into our brains that you need to demonstrate tubal patency before you run an IUI cycle, because the worst thing that could happen is if she has blocked tubes, she lands up with an ectopic pregnancy. Rubella immunization status is probably more relevant for Western countries because most of our women are immunized, but at least it needs to be documented on paper that the IgG is positive. I see many couples who have undergone IUIs elsewhere where the male partner has not been investigated at all. There is no male partner infection screen. He directly comes on the day of the IUI, gives a semen sample, and before that, even semen analysis or testing is not done because he's never shown up to the test. He never thought it was a couple's problem, like we always say. Lifestyle modification, you can see this slide, lists all the important take-home messages for couples when you are starting the treatment. Ideally, you need to enforce these for at least 3 months before you run a treatment cycle. In an exact world, in a perfect world, in an ideal cycle, we would like to do that, but we don't have the luxury of time and choice in most modern clinics. Ovulation tracking and fast track, all that we have to cover very soon. So when you counsel your couples, you're going to talk about what is the indication, protocol that you use, the financial issues and the repercussions. We're going to talk a little bit about semen freezing. If the male partner has issues with producing a sample, always have a backup semen sample. Infection screening of both partners needs to be there on paper, by law, and there are many clinics which don't ensure this. So please, for heaven's sake, make sure that this is there on paper. You need to inform the male partner well in advance as to what are the likely dates and times when he needs to be around. And the collection specifics are well most of us, but they need to be communicated, especially for me as male fertility physician. It's very easy to talk to the male partner about the precautions that they need to take when they are collecting the semen sample or clinicians sometimes embarrassing. So that can be outsourced to somebody else. The preferred ovarian stimulation protocol, which is to be the focus of today's discussion. If you use clomipene or letrozole only, which means oral ovulogins, this is probably outdated. The most common protocol that we use in clinical practice today is clomipene or letrozole with gonadotropins, and this is the most preferred methodology. Not all patients will need letrozole plus gonadotropins. Clomipene plus gonadotropins is still a very good protocol, especially unexplained patients, and the evidence is there for that. As far as gonadotropin only protocols are concerned, they come with a stigma. And remember that there is a risk HSS, and you will need to learn how to titrate your gonadotropin dosages before you move directly to gonadotropin protocols. Again, they carry the risk of multiple gestation, a last minute conversion to IVF cycle, OHSS, and so on and so forth. And therefore, try to avoid this. Of course, they're also cumbersome and quite expensive to use in daily routine clinical practice. And the last item that we need to discuss is gonadotropins with GnRH antagonists. If you're like me and you travel every weekend to work in different places to deliver 4 or 5 different lectures, then you need to avoid weekend work. Also, your embryologists are not very happy when they are asked to come and do semen processing and embryology work on a Sunday. Then they would rather be with their families, and therefore GnRH antagonists do have their place as far as scheduling is concerned. Whether it leads to better clinical pregnancy rates, we will come to that in just 4 or 5 minutes. I found this beautiful paper, which was published very recently. I think it was December 2022. And this looks at the application of letrozole plus HMG in artificial insemination partners. They had about 526 cycles, and they found the clinical pregnancy rate of the letrozole HMG group was 25% versus 15% for the pure HMG group. Now, this is completely against what is standard conventional wisdom. We've always thought that pure HMG or pure FSH cycles are going to give you better clinical pregnancy rates, but there you have it. The evidence is there that that's not the case. Letrozole plus HMG works out cheaper, lesser duration of stimulation, lesser multifollicular development, lesser chances of complications, and still seems to give you better clinical pregnancy rates. In fact, The live birth rate was almost 20% versus 11%. Again, this is something which is quite surprising. Therefore, they found that this protocol is quite cost effective, useful, and probably should be the way to go. I come back to the old Cantino-Cochrane meta-analysis published in 2021, and they found that the improvement of live birth rate with gonadotropins is quite significant. Therefore, gonadotropins patients should be used, which already said earlier. So why to use gonadotropins? If you wanted a single slide summary, and if you're a trainee or you're a student and you're preparing for an exam and need a Viva answer, there are all the points in favor of gonadotropins: multifollicular development, better quality oocytes, better endometrial thickness, better receptivity, and synchronized cohort of follicles. This is one nightmare that mention has, and I'm sure Dr. Jatin will address that in his talk when he talks about stimulations for IVF cycles. On the other hand, nothing is perfect. Life is not perfect. There are always some issues, and here you know that gonadotropins are expensive. You need more frequent clinic visits. There can be errors in administration, cold chain maintenance, batch-to-batch consistency issues, and of course, the cost of a cycle goes up. The practical tips and tricks that all of us need to know regarding gonadotropin. And as I said at the beginning of this talk, if you're somebody who does stimulations very regularly, somebody who practices IVF, this is going to bore you. But these safety tips and tricks are of paramount importance for a beginner clinician, somebody who's learning to use gonadotropins in daily practice. And therefore, they must be said if you're going to speak for half an 40 minutes on ovarian stimulation. Always do a baseline scan, look at the antral follicle count, rule out residual cysts. Always start the lowest possible dose. If you think you can get away with 75, use 37.5. If you feel you can get away with 150, start 75. As far as HMG, FSH is concerned, both are equivalent in clinical practice. There is no difference in either the quality of the oocytes in an IVF cycle or the number of oocytes in an IUI cycle. And therefore, for cost effectiveness reasons, we would prefer to use highly purified human menopausal gonadotropin, which is abbreviated as HPHMG. Always monitor the patient personally. There may be some role for monitoring of E2 and LH at the beginning of your journey as a fertility clinician. As you grow older and more experienced, you'll probably not want to spend all that extra money and keep poking the patient every 2 days to look at hormone levels. Most of us have moved on from that, because it's not even evidence-based and it doesn't necessarily prove your success. And as we said earlier, gonadotropins give you the most cost-effective cycles. The starting dose of gonadotropin, as I have been so fond of telling my trainees for the past 10 15 years, is what makes or breaks your entire treatment cycle. You start with the correct dosage, you get the correct number of follicles, you get synchronized development, you get perfectly good, healthy endometrium, and hopefully, fingers and toes crossed, you end up with pregnancy. If on the other hand, you start with too less, then you botched it up, you give too much, you'll end up with ovarian diversity. And this is a beautiful nomogram which was published ages ago, almost 20 years back, which looks at the starting dosages vis-a-vis the number of antral follicles and the weight of the patient or the BMI. And for most patients, you would find if they are less than 60 kilos, a starting dose of 50 or 75 IU is perfect. You would only need to exceed that if you were looking at a slightly heavier patient who had greater BMI. So this is the one simple safety trick. There's also something called as the Sono scoring system, where you look at the age, BMI, antral follicle count, the ovarian volume, and the stromal RI and PSV. And these are given a score from 1 to 5. And based on the total cumulative score, after you've assessed all the 5 parameters, you can decide your starting dose of gonadotropin. This is excellent if you're a student or you're a trainee and you're appearing for an exam and you want to wow your examiner. For most of us in daily clinical practice, we don't actually do it in this cumbersome fashion. It's always good to have this knowledge and know that there is a system, and if you're appearing for an exam, you can always give your exam that you have certain in-depth knowledge. It's not all just guesswork that we are working by. We have this Cochrane on gonadotropins in PCOS, which is now called PMOS, and here they look at nearly 1,700 plus women, 14 trials. And here they found that whether you gave recombinant FSH or you gave HMG, there is no difference in the clinical pregnancy rates or the live birth rates, which means, translate that into Indian clinical practice, use HMG for most case scenarios and you will be absolutely fine. I found one more beautiful article, and this is from France. This is published in 2017. And this looks at 1,251 cycles, which is a huge number of cycles, a large body of evidence, and you can't clearly ignore it. They say that there's no difference in clinical outcomes between different stimulation protocols, whether it's urinary, recombinant, or HMG that you use. But if you had multiple factors or you had unexplained infertility, significant impact on IUI success. Fourth attempt, the female partner over 40 years, all of these were detrimental conditions and you should not offer in those patients. How do you monitor the cycle after you've started your gonadotropin? Usually you would do a transect vaginal scan, always do a baseline scan, make sure that you're trained in ultrasound, and for heaven's sake, make sure your name is there on the PCP and UT certificate before you touch the probe. I cannot stress this now. You need to have all the appropriate signage regarding sex determination, all that, not done here, etc., etc. As per the law of the land, and please do not take this lightly. This has to be documented very clearly. Your baseline scan is on day 2. You do your follow-up scan where you do it 3 days later. You look at readiness for ovulation trigger, and that's usually when the follicle reaches a diameter of 20 to 22 millimeters for letrozole plus HMG cycle. If it's a pure HMG cycle, then you would give it somewhere around 18 to 20. And in an IVF cycle, of course, it's 17 to 20. If it's a pure oral ovulation cycle, you can delay it even longer, up to 24 to 25. Most of us don't do pure oral ovulation IUI cycles. There is some evidence that you can add color Doppler for optimizing the trigger timing, but it's controversial and large studies have shown that there may not be significant benefit, and therefore many of us don't use it routinely in clinical practice because there's no 1:1 correlation with adding color Doppler. Do we also need to have biochemical monitoring? Now, this is something which is a concept which came to us from IVF and it's been used since the 80s and 90s, in fact, since the days of Louise Brown. And I have this beautiful Cochrane meta-analysis where Siladitya Bhattacharya was also one of the collaborators. And they found that evidence does not suggest that combined monitoring with ultrasound and estrogen monitoring is more efficacious than just ultrasound alone. Today, we have good high resolution probes. In fact, I'm very fond of saying that sometimes the probes show you more information than your mind can actually process. What the mind does not know, the eye does not see. And that is very true for our modern 8 methods tools, which are ubiquitous now in clinical practice. And in most clinical cases, you will not need to do serum estrogen monitoring, except in those patients where you're suspecting either there is no response to your stimulation or there is a hyper response to your stimulation. Those are extremes. And in those cases, probably your estrogen monitoring is going to be beneficial. I'm going to close with a few simple important questions that also need to be asked. And is there a risk of multiple pregnancy? I found this paper published in Obstet Gynecol, May of 2020, and this looks at the mature follicles or your leading follicles when you're ready to give your trigger and the risk of multiple gestation. And this is a huge body of evidence, nearly 25,000 women undergoing more than 50,000 IUI cycles. They found that if you increase the number of mature follicles from 1 to 5 at the time of the insemination, then the clinical pregnancy rate increased from 15% to about 22%. But at the same time, there was a marked increase in antenatal gestations from 0.6% to 6.5%. Now, in most ART programs, I think you will agree that any number of multiple gestation, which is more than, say, 4 or 5%, is something which is not acceptable, at least for IUI. In an IVF cycle, maybe you would get away with 8 to 10%, but even that is actually quite high. And that is why many of us are now moving towards elective single embryo transfer, notably blastocyst transfer. Again, this will be addressed by Dr. Gatincha in his talk. But as far as IUI is concerned, there is little increase in the number of singleton pregnancies per started IUI cycle. regardless of the mature follicle. So don't cancel your IUI simply because you got one follicle. At the same time, don't cancel your IUI because you got 4 or 5 follicles. You can always fast track for to ART. Of course, many patients will not accept that sudden increase in financial burden, but that's something which you can definitely offer. They conclude by saying that caution should be used when proceeding with IUI after ovarian stimulation when there are more than 2 mature follicles because there is a substantially increased risk of multiple gestation without an improved chance of single-to clinical pregnancy. And this, I think, is the overwhelming take-home message as far as safety with gonadotropin usage is concerned. And the last question that we need to address is, does addition of GnRH antagonists improve clinical pregnancy? It's all very well for me to joke about it, that because I deliver a lot of lectures on weekends and because my embryologists don't want to work on weekends, we should be postponing cycles by using GnRH antagonists. This is a slightly older +1 meta-analysis in 2014, where they had about 2,500 cycles. And they found that additional GnRH antagonists can significantly increase the clinical pregnancy. Also, Christophe Blofield and his colleagues in Belgium, Brussels, the University of Brussels, where I also studied in my idea, have proven that postponing your trigger by 24 hours does not necessarily impact your clinical pregnancy rate. And that is something which comes as a relief for many of us to feel that when she is ready, you give the trigger. It's okay, I will adjust, I will cancel my other commitments, and I will see to it that I will be around on Sunday. That doesn't necessarily matter. Just 24 hours delay with the GnRH antagonist and then delaying 24 hours works just as well. This is the continuum meta-analysis, again, which I'm quoting. And what they said at that time in 2021 is that it's uncertain whether GnRH antagonists significantly improve live birth rates. So the evidence is still equivocal whether you use it routinely or only to postpone weekend IUIs. The choice is entirely yours. The overwhelming message is that use gonadotropins in the right dose at the right time for the right reasons, because patients are waiting for a very short period of time. And it is incumbent on us to try and give them the maximum possible results in the 1 or 2 cycles that they stay with. So, ladies and gentlemen, to conclude, a few key practice points. IUI is something which we all take for granted because we do thousands of such cycles. Unfortunately, low success rates are seen in the best of hands. Optimal patient selection and pre-treatment good counseling is of paramount importance. There are multiple points where expertise of the clinician is necessary, and addition of gonadotropins, 1:1 doctor-patient ratio, good monitoring with ultrasound yields the best results. Have no fear of perfection. You are never going to reach it. And as we've seen, you can get success.
So Dr. Pratik had recorded this lecture because he is physically in a program on Doctor's Day, but he will join us shortly for the Q&A session once Dr. Jatin Shah finishes his talk. So I hope we all enjoyed. Apologies for a little bit of audio disturbances, but this talk of Jatin sir and Pratik sir would be recorded on YouTube and will be available for anyone who wants to watch it later. So before we move to our second speaker, I would like to thank rest of the 15 societies of Maharashtra who have collaborated today with us. Dr. Vishal, would you like to show the pictures? We would like to thank the dignitaries belonging to Hingoli OBGY Society, headed by President Dr. Archana Saraf and Secretary Dr. Snehal Masare. We would like to thank Ichal Karanji OBGY Society, headed by President Dr. Mandar Deshpande and Secretary Arushi Kajave. Islampur OBGY Society, headed by President Dr. Hanuman Patil sir, I think sir has joined also, and Secretary Dr. Yogesh Jadhav. Jalgaon OBGY Society, headed by President Dr. Vaishali Chaudhary, Secretary Dr. Anita Baviskar. Jalna OBGY Society, headed by President Dr. Smita Kulkarni and Secretary Dr. Smita Pandit. Karad OBGY Society, headed by President Dr. Preeti Deshpande. Kolhapur OBGY Society, headed by President Dr. Manishi Nagaonkar and Secretary Dr. Ranjit Kiledar. Latur OBGY Society, headed by President Dr. Amir Sheikh and Secretary Dr. Vishnu Tarse. Loni OBGY Society, headed by President Dr. Vidyadhar Bangal and Secretary Dr. Harshada Maske. Malegaon OBGYN Society headed by President Dr. Mayur Shah and Secretary Dr. Samarth Borade. Miraj OBGYN Society headed by President Dr. Sharvari Jadhav ma'am. Madam is with us since the beginning of the program, and her Secretary Dr. Nisha Halingale. Mumbai OBGYN Society headed by President Dr. Shailesh Kore and Secretary Dr. Sujata Dalvi. Nagpur OBGYN Society headed by President Dr. Sangeeta Tajpuria and Secretary Dr. Meghna Agarwal. Nanded OBGYN Society headed by President Dr. Meenal Patil and Secretary Dr. Rama Kadam. And last but not least, Nashik OBGYN Society, Dr. Manisha Jagtap as President and Secretary Dr. Meenal Randive. This finishes our 30 societies of AMOX who have collaborated with us. The last 14 we will be introducing before the panel discussion. And now I hand over the session to Dr. Virul Srivastava to invite the chairpersons.
Good evening, everyone. Now we are proceeding towards our second session, which is on the topic controlled ovarian stimulation IVF. And first, I'd like to introduce our chairperson, Dr. Amir Sheikh sir. Sir is president at Latur Obsgenic Society. Welcome you, sir. Next, we have Dr. Hanumant Patil sir. Sir is president Islampur Obsgenic Society. We welcome you, sir. Next, we have Dr. Pranita Revankar ma'am. Ma'am is president Pusad Obsgenic Society. Welcome you, ma'am. Next, we have Dr. Preeti Deshpande ma'am. Ma'am is president Karar Obsgenic Society. We welcome you, ma'am. Next, we have Dr. Rama Kadam ma'am. Ma'am is president Nanded Obsgenic Society. Welcome you, ma'am. Next, we have Dr. Rekha Thote ma'am. Ma'am is president Thane Obsgenic Society. Welcome you, ma'am. Next, we have Dr. Sangeeta Tajpuria ma'am. Ma'am is director at Vedans Hospital and Test Baby Center, and she is also president in Nagpur Obsgenic Society. We welcome you, ma'am. Next, we have Dr. Shalaka Mamidwar ma'am. Ma'am is president at Chandpur Obsgenic Society. We welcome you, ma'am. Next, we have Dr. Sharad Shinde sir. Sir is secretary at Bheed Obsgenic Society. We welcome you, sir. Next, we have Dr. Uma Wankhade ma'am. Ma'am is president at Pune Obsgenic Society. We welcome you, ma'am. Next, we have Dr. Vinayak Khetkar sir. Sir is president at Aurangabad Obsgenic Society. We welcome you, sir. Next, now I request our chairperson to introduce our keynote speaker, Dr. Jatin Shah sir. Ma'am.
I request Hanuman sir or Shalaka Mamidwar ma'am, please unmute yourself and introduce our speaker, please. Chairpersons for this talk. Do the honors. I will do the honors.
Yes, ma'am.
It is my extreme pleasure and good fortune to introduce before you the one and only Dr. Jatin Shah sir. First of all, sir, a very warm welcome to Synergy and a lot of a big, bouquet of thanks to you for saying yes to our invitation. I'm forever troubling, sir. I think every 6 months or so, I get that, I have to invite Jatin, sir, and he always says yes. So, sir, you are the epitome of how to improve success rate in IVF IUI. You don't go by the book, you don't go by studies. I think your success doesn't collaborate with any of the literature. It is a literature in itself. What Jatin Shah sir does and teaches becomes something like a sacred information to all of us, and we all try to inculcate something or the other from your talks and your practice in our humble practices, because the volume of work you do and the passion with which you do it and the amount of effort you put into your success rate is something that only history is made up of. So, sir, the stage is all yours. Please start your deliberation.
Thank you so much, dearest Monica, Randir, all the distinguished senior faculty members. I see a lot of friends, Dr. P.K. Shah, Dr. Rajendra Nagarkatti, Parag, Vishal, all the others. Of course, Team Synergy. Monica always does such a fantastic job to organize such a great meeting online. It's truly overwhelming to be in the midst of more than 80 presidents and secretaries. And I'm grateful once again to Team Synergy and Monica for having me here today. Today, I'm going to talk on a very, very important topic because, we are no longer in an era with so many clinics that we can just have one standard protocol for each and every patient who walks in. And we know that we need to categorize patients and we need to individualize every possible step of the IVF cycle to make sure that we get the best outcome for our patients. And that means selecting the correct protocol, selecting the correct analog, whether it's going to be an agonist or an antagonist, selecting the correct FSH and HMG, selecting between rec FSH and urinary FSH, selecting the correct ratio of FSH and LH, whether you want to do 1:1, 2:1, or 3:1, whether you want to delay the trigger because of a poor crop of M2s in the previous cycle. Do you prefer to give just the HCG trigger or just the agonist trigger or a dual trigger? Would you like to do a delayed triggering for PCOs who have recurrent early pregnancy losses? Would you like to do a cleavage stage transfer if she's, say, 37, 38 with just 2 good quality embryos on day 2 or day 3? Or would you rather do your blastocyst? And of course, finally, would you like to put all your add-ons like PGT and LATE and ERA and all the other add-ons that we have, intraovarian PRPs and hysteroscopic PRPs, and where would you judiciously use and add on these so-called add-ons that we have in IVF? So to begin, of course, we must always remember that we all exist as IVF specialists thanks to a life-changing event that occurred almost half a century ago at the stroke of midnight, 25th July 1978, when Robert Edwards, Patrick Steptoe, and Jean Purdy gave us Louis Brown. Louis Brown was born from a natural unstimulated cycle. They just did a urinary LH detection to time the egg retrieval well past midnight, that to a laparoscopic egg pickup, and she had a fresh cleavage stage embryo transfer. Today, we cannot even dream of doing such practice because we need complete control on our ovarian stimulation cycles, and which is why we call it COS for IVF. And we need control in the sense that we want to make sure there is no premature LH surge. We can do all our procedures well within early morning or late morning laboratory timings. And we can do good vitrification and not just aim for one live birth, but try to give the patient a good cumulative live birth rate from one good ovarian stimulation cycle. So what are the changing trends that we have for this year? And one very important point, which I still see that most clinics tend to neglect. Patient walks in on late day 2, early day 3, sometimes day 4. You don't want to lose the cycle and you begin stimulation, and then you see total asynchrony on day 7. Pre-treatment is mandatory in all your antagonist cycles. Remember, if you don't do pre-treatment, you have a 30 to 40% chance that you will have one follicle racing ahead on day 7 and the other follicles lagging behind, creating huge clinical dilemmas as to when to trigger and when to do the egg retrieval. Number 2, I keep telling for the past 1 decade that the agonist is far superior to the antagonist for all your Poseidon groups. And I'll show you a lot of evidence why this is so. Number 3, please be careful when you keep recommending intraovarian PRPs, stem cells, and so on, and so many add-ons. What is the available evidence? What are the RCTs that we have available today? Are they really efficient or are they just a false ray of hope? Number 4, we have now a unique way of delaying triggering for some PCO patients who have recurrent early pregnancy losses. And I'll also convince you that you need to give LH to each and every patient, whether she's the poorest of responders or the highest of responders, in order to get the best possible outcome for her. So what do we mean by individualize, and how do you individualize your patient? And to help you do that, you have to, of course, look at age, BMI, AMH, AFC, and whether she has associated PMOS and endometriosis. But the most important, I'm sure 80% of all of those who are present on the webinar today must be encountering patients who have failed IVF in the past. And that details of that cycle of the past is your biggest clue and step to success. You must go back in detail and find out what exactly was the protocol used, when was stimulation started, was there asynchrony on day 7, was the trigger given on time or was it delayed to avoid a Sunday retrieval, was it a cleavage stage transfer, what was the trigger used, was it a fresh or a frozen, was it a blastocyst, was it a PGT done embryo? Each and every detail so that you don't repeat the same things and you try to give her a perfect tailor-made stimulation protocol, which will probably give you success if she has failed in the past. So of all these points, previous response and her past IVF cycle studied in detail is the most important step to achieving good success. Remember what we heard at the Paris ESHRE, that AMH measurements which are older than 3 months may not be very accurate as far as prediction of response goes. So please, at least personally, I look at the AMH, of course. I try to look at a level which has been done within the past 3 months. But more importantly, I feel antral follicle count is a very important predictor of the response, especially in short antagonist cycles, if you have not given her a birth control pill as pre-treatment. Using older measurements, as this paper showed, might be associated with a over-prediction or under-prediction of the final egg yield. So previous response, I already told you, and Zabaleta in 2023 showed in a Delphi consensus that the most valid starting dose prediction factor is her response in a previous cycle. Of course, if she's not had a previous cycle, then AFC and AMH and age are the most reliable to depend on to decide that what should be her starting dose. But despite all your best efforts and all my best efforts, and however good you may be, you will invariably end up with your Poseidons 1 and 2. So these are your young and old patients. She came to you with a normal ovarian reserve. You expected her to give you 15 to 20 oocytes with a dose that you thought was adequate for her. And yet she gave you either less than 4, that is subgroup A, or she gave you 5, 4 to 9, subgroup B, and she became a Poseidon 1 or 2, totally unexpected. And then, of course, you have your Poseidon 3 and 4, which are your young and old patients who come to you with a reduced ovarian reserve. And all of you would agree that today the greatest epidemic that we are facing is that of Poseidon 3. Without any exaggeration, we just looked at our past 6 months and we found that more than 50% of our cycles were the group of Poseidon 3. So these are young patients under the age of 35 coming to you with low or very low AMH levels, very low antral follicle counts, and they can really pose a challenge. But the good thing and a very good counseling point for these patients is that if you compare them to a normal responder, yes, she will give less oocytes, but fortunately, the oocyte and embryo quality in a Poseidon 3 is usually on par with a normal responder of the same age. So when you are counseling them, you have to tell them that yes, you will give fewer eggs, but generally the quality is good. And as a lot of studies have shown that if your expected pregnancy rate with a normal responder is say around 45 to 50%, your Poseidon 3 will still be a very good 40%. So that is, of course, heartening news for the Poseidon 3 group. But you also have to counsel them that you may not have enough extra embryos for freezing. So your cumulative live birth rate might go down because you will not have so many attempts at frozen embryo transfers. And therefore, you might be required to do repeated cycles. If you're looking for a family of 2 or 3 children, then it would be ideal to pool some embryos with 2 to 3 good stimulation cycles and then begin doing the embryo transfers. But Poseidon classification is not enough to put you on the right track. And here you need to be very careful of one particular group of patients. And we now have a deeper understanding of the pathophysiology of this group. So we now know that there are 4 groups. Number 1, the compensated stage, where she will respond well. Whatever protocol you use, she will generally do well. So we are not worried about this group. They will have a good 28 to 30-day cycle, low AMH, but will respond well. Number 2, the most important is the patient who is in a stage of desynchronization. And this is the patient you have to be very careful about. Number 3 is a stage of pathological premature LH surges. Very often you see she was 17 on Monday, 17 on Tuesday, 17 on Wednesday. You thought you will step up the dose, trigger her on Thursday, and Thursday she comes with a premature rupture of the follicle. And number 4, stage of suppressed follicle growth, which is the very, very bad cases, really poor responders, where usually nothing works and oocyte donation might be required. So to highlight this stage of desynchronized cycles and why pre-treatment is so important for this group is that, these poor responders have inhibin levels falling in the luteal phase of the previous cycle. And therefore, the selection of the dominant follicle also begins in the late luteal phase of the previous cycle as against the earlier follicle phase of the current cycle. So you have a blending of the late luteal and early follicular phases. The way to diagnose this patient, she comes with a low AMH. She has a normal FSH on day 2, which is the clue instead of elevated FSH because she has a high E2 on day 2. So what has happened? The dominant follicle was already selected 3 or 4 days before menses. It started secreting estradiol, which gave a negative feedback, which normalized the FSH level. But when you see her on day 2, she already has a follicle of 12 to 14 millimeters. Very often this is ignored. Stimulation is started and this follicle is 18 to 20 on day 7 and your newly recruited cohort is still around 10 to 12 mm. They will also tell you that, doc, I used to have 28 to 30 day cycle lengths until a year ago, but now my cycles have become shorter. I get my menstruation, say, at 22, 24, 26 days. These are very important clues that this is the patient who will have desynchronized growth because the dominant follicle was selected in the late luteal phase of the previous cycle. So be very careful of this particular group. So if you look at the causes of the various Poseidon 1 and 2s, low gonadotropin starting dose is one of the causes listed as number 1 in this slide. Then, of course, you have your 10 to 15% of patients who have polymorphisms of the FSH and LH receptors, rendering the ovaries relatively insensitive to exogenous gonadotropins. They might need a slightly higher dose of FSH, but more importantly, they need more LH right from the beginning rather than stepping up FSH to very high levels. Number 3, the trigger. Your trigger may not have been adequate. You may have given it a day or two early. You may have given it a day or two late. You may have used only HCG and maybe the trigger didn't work well. So you had 10 oocytes, but you had only 4 metaphase 2s. And number 4, which should actually be number 1, is asynchronous follicular development. And this is the number 1 cause that you had 10 follicles, but you got only 5 eggs. You had 5 eggs, but you had only 1 M2. You had 2 M2s and you didn't get even 1 top quality embryo. And this is where synchronicity of follicles is very, very important to achieve. So let's begin with the starting dose. And we just don't look at human reproduction all the time because, you know, whenever you pick up a European human reproduction article, in materials and methods, you will see the standard starting dose that they usually have is 150 of rec FSH. Please look at Indian studies. We have a study from Padma Rekha Jirge and Fadi Sharara 2022. Clearly showing that Indian ovaries are not as sensitive as Caucasian ovaries, and our starting doses should be 225 or even 300, and we should not be using low doses like 150 or 187.5 for any group of patients. Most important, pre-treatment. Now here I keep repeating, why is pre-treatment important? Why is it important that in a Poseidon 3 or 4 where you are expecting only 4 or 5 oocytes or a 1 and 2, it is important to get that every extra metaphase 2 oocyte. And you can see here Bosdag's classic study from 2017 that if with 1 metaphase 2, your live birth rate expected is around 4%, with 4 oocytes, you go up to 16%. So you can see the increase in live birth rate that you have with every additional oocyte. And of course, all of you remember Sankara's classical study showing the same, that once you cross 2 or 3 oocytes, your live birth rates keep increasing till 15 oocytes in fresh embryo transfers, and then of course fall in fresh air transfers because you have supraphysiologic estradiol levels and so on. But nowadays we all do freeze-all if we have more than 12 to 15 oocytes. So this is very important to remember, that don't take it lightly. If you had 5 follicles, you got 5 oocytes and your biologist says 3 M2s, don't feel happy about it because something has gone wrong. You should have got 4 or 5 metaphase 2 oocytes for this patient. And it's so easy to achieve follicular synchrony. The simplest way to do it is luteal estradiol valerate. Very simple, very cost effective, very popular. You just have to give her 4 milligrams a day, 2 milligrams BID from day 22, 24, 25 as per her cycle length, starting maybe 5 days before her expected menses, to prevent that dominant follicle from being selected in that patient who has a desynchronized cycle. Even for your normal responders, you should give this. Suppose she comes in on a Monday, which is day 2. She's on luteal estradiol valerate. You will see there is no dominant follicle in any patient. But you don't want to start stimulation because egg retrieval will be on a following weekend. You just continue the luteal estradiol until Thursday. You then begin stimulation from Friday. So bleeding will stop because of the estradiol. You will have a triple line endometrium on Friday. You won't have the classic shedding that you see on day 2. But you will not have a dominant follicle. So now when you begin your FSH or HMG, you will get a perfectly synchronous cohort. The other simple way of doing it is just giving norethistorosterone BID. Again, from mid-luteal phase, you can give it for 7, 10, 15 days. Normally, I would stop it on a Sunday so that I can have a 5-day washout period and begin stimulation on a Friday. Again, this would ensure synchrony. If you just see a dominant follicle on day 2 and she's a patient from overseas, she cannot wait for the next month. And you know that if you start today on day 2, she will have a asynchronous cohort because you are already seeing a dominant follicle. The best approach, give her the antagonist on days 2, 3, and 4 and call her in on day 5. You will see the follicle has been completely suppressed. You will see the endometrium is nice and shrunk and atrophic. You now begin stimulation, call her in after 5 days of gonadotropins, add back your antagonist at 14 mm, or if you have a fixed day start on day 6. The only caution here is don't start with FSH alone. Antagonist will give very severe suppression of endogenous FSH-LH, and you will have to begin 75 or 150 LH when you start FSH from day 5. And this is where most people go wrong, because they just give FSH and then they tell me, oh, we tried your antagonist, but the response was very slow and she took 10 days to reach 14 mm. This is because you did not add LH right from the beginning. And the same holds true for birth control pills as well. If at all you still find options 1, 2, and 3 not too good, you can use a low dose birth control pill, not the high dose. Give it from day 2. Do not give more than 10 to 12 days. Again, stop on a Sunday, wait for the mandatory 5 to 7 day washout period, and then begin stimulation from Friday or Saturday to make sure that your egg retrieval is on a weekday, that is between Monday and Wednesday. The antagonist on days 2, 3, 4, besides taking care of a dominant follicle, is also very useful if you just want to tide over a weekend retrieval. So she comes to you on a Tuesday as day 2. You know, if you begin stimulation, her retrieval is likely to be on a next Sunday. So you give her the antagonist on Tuesday, Wednesday, and Thursday and begin stimulation from Friday. So you have not lost a month, you've not lost 15 days, you've not lost a week. You have just postponed the egg retrieval by 2 or 3 days. Now, some of you may argue that why does he always say no for the birth control pill? When you pick up any fertility, sterility, each and every American clinic uses birth control pills for scheduling. We know that doctors in the US do not like to work from Friday afternoon to Monday morning. So each and every patient is on a birth control pill, not just 10, 12 days, maybe even 15, 20, 30, 40 days. A lot of us in India who were doing batch IVF also used to give the pills for prolonged periods of time. But just go a little further in material and methods, and unlike human reproduction and European articles who start with 150 rec FSH, most 99% of American clinics begin stimulation with a combination of FSH and HP-HMG. You will rarely see FSH alone protocols in any fertility sterility articles. And this is the reason why, because they've used a prolonged birth control pill, they have to begin with a combination of FSH and LH so as to make sure they get an appropriate response at the right time. Also, the washout period of 5, 6, or 7 days is mandatory to ensure that you get a good ovarian response. Finally, of course, coming to the best way of dealing with all your Poseidon groups, making sure that there is no desynchronized stage, ensuring that the dominant follicle doesn't or can't get selected in the luteal phase, ensuring that you just cannot have any pathological premature LH rises, and ensuring that you get, because you get a synchronous cohort, you get more oocytes and more embryos and a better clinical outcome. So for those of you who are beginners, how does the agonist work? Initially, it gives a flare. Normally, we only stick to the mid-luteal, that is the long agonist protocol. So you begin on day 21. You might get a flare. The corpus luteum might flare up for a few days, but then it usually gets suppressed, because with prolonged agonist administration, you will then have complete downregulation and profound desensitization, complete cutoff of endogenous FSH and LH. The downside is, because you have complete cutoff of endogenous FSH and LH to 0 levels, you have to begin with a combination of FSH and LH, and you have to give 75 more IU than you would have given her in a short antagonist protocol. Antagonist, on the other hand, it has an immediate effect. there is a dose-dependent suppression of gonadotropin release within hours, and we know that there is a recovery too, so you have to give it on a daily basis. But of course, there's no initial flare-up, and there is no severe suppression of endogenous LH, unlike the agonist protocol. Now, which protocol, I already mentioned this earlier, gives you perfect synchrony, gives you more oocytes, more embryos, no selection of dominant follicle, no premature LH surges, and as studies have shown, better quality oocytes with less cytoplasmic irregularities, more zygotes with normal 2PN morphology. And now, in the days where we are trying to rejuvenate fresh embryo transfers for a lot of poor responders, better endometrial receptivity for successful implantation. And it is clearly proven, many studies now, that the endometrium receptivity is much better in the long agonist protocol as compared to the short antagonist protocol where fresh embryo transfers are concerned. Do I have evidence to back it up? Yes, I always do. And this is a study by Zhu in 2019. You can see more than 500 patients in each arm. The clinical pregnancy rate with the agonist at 58% as against 32% with the antagonist in fresh IVF transfer cycles, and live birth rates again almost doubling from 25 to say 46% when the agonist was used. An even better study was done by Huang in 2018, which especially focused on our most common group, and that is the Poseidon group 3. You can clearly see with the agonist, your live birth rate is up to 31% as against just 16.7% with the antagonist. Why are pregnancy rates lower with the antagonist in fresh transfers? As I told you earlier, significantly lower HOXA10 expression in the endometrial stromal cells in antagonist cycles, and there is a tendency to a thinner endometrium as compared to the agonist cycles. Moving on then to the trigger, many a times you have so many follicles, but you don't get enough oocytes, you have enough oocytes, but less M2s, and this usually is related to the trigger. We all have a mental perception that HCG is the best trigger because we used to get so much of OHSS in the good old days 15 years ago that it is a nice and strong trigger and gives the best outcome. Just go back to your Spiroff and look at a normal menstrual cycle. You will see that at the mid-cycle, there is not just an LH peak, but you also have a surge of FSH. Now, HCG only simulates the LH peak. When you give an agonist trigger, you cause a release of both endogenous FSH and LH, and which is why it is a much more physiological trigger than HCG. The only downside is that it does not have a long half-life. There is abrupt luteolysis. Patient might menstruate within 3 or 4 days of egg retrieval, so you cannot do a fresh embryo transfer, and you have to do a freeze-all whenever you use an agonist trigger. But if you have freeze-all in mind that this patient anyway is going for PGT or anyway has too many oocytes or whatever other reasons you have for doing frozen transfers, please remember that your agonist trigger is superior to HCG as far as conversion to metaphase 2s are concerned. But in poor responders where you have less oocytes and you want maximum meiotic maturation and conversion, the dual trigger works the best. And this is a good, wonderful study from 2019 comparing HCG alone versus HCG with 0.2 milligrams of triptorelin, that is the agonist or the dual trigger. And you can see live birth rates up from 14.5 to almost 27% when the dual trigger was used. So for your poor responders where fresh transfer is not being done, you can or you must use a dual trigger to get your maximum crop of metaphase 2 oocytes. So as I already told you, is the agonist trigger just like is a original diamond better than a lab-grown diamond? Same way is the agonist trigger better than HCG. And we have a study from Krishna in 2021, which compared cumulative live birth rates between HCG-generated embryos, frozen embryos, and agonist trigger-generated embryos. And you can see the agonist-generated embryos had a much higher cumulative live birth rate than HCG-generated embryos. So this clearly proves that the agonist trigger is far superior to the HCG trigger when fresh transfer is not being contemplated. For Poseidon 3s and 4s, of course, you have enough time, you are forewarned. But remember that PGT is not the answer to all their woes. You have to remember that the genetic spindle is probably the smallest part of the oocyte. And what we are more worried is the mitochondrial DNA. And we know that the oocyte not transmits not only the mother's nuclear material, but also her mitochondrial genome to the embryo. And we know that mitochondrial defects are very common in Poseidon 4, especially after the age of 35. So there come in our adjuvants. And remember, we are flooded with adjuvants from each and every company with so many micronutrients being mixed up in these capsules. We really need to know what is the evidence for the use of these supplements. And the only evidence that we have very strong. Number one, coenzyme Q, especially its active form ubiquinol. Number two, androgens, DHEA and transdermal testosterone. And number three, growth hormone. So these three have a lot of evidence to back them up. Zoo study in 2018 clearly showing 200 milligrams TID of coenzyme Q, 60 days pre-IVF recommended for Poseidon 3 and 4. Growth hormone, this was one study from 2023, which showed a significant improvement in clinical pregnancy rates with growth hormone. But a word of caution that there are too many different regimens, too many different doses. We still don't have any standardization. It's a very expensive drug. So we need some more RCTs to tell us that should we start in the late luteal phase or on day 2 or on day 7, should it be 2 mg, 4 mg, 8 mg, 12 mg. And until we have more clarity, I would caution you that let's wait for the exact regime to really get the best out of growth hormone. Androgens, of course, we went back and forth. Finally, Polizos in 2022 showed higher number of oocytes and higher live birth rates with testosterone use. The same author then did the T-transport trial where he gave 2 months of a very low dose testosterone followed up with the long agonist protocol and HMG stimulation and found no difference in outcomes. Personally, I still strongly believe that if given the correct dose, at least for 21 days pre-stimulation. So what we do is 2 actuations a day of the gel, the transdermal gel from day 6 of the preceding cycle, which then continues until day 2 of the stimulation cycle, or if it's a long agonist, then until you start FSH. So usually about 20 days pre-stimulation is ideal with transdermal testosterone to get the best outcome. How high to go with FSH? Usually, I would not recommend going beyond 300 or 450 as per the BMI of the patient. Going to 600 or 1200, what used to be practiced in the past, doesn't really help. You can't flog a dead horse back to life. That patient has just that many follicles. And a wonderful study from 2019 comparing different doses of REC-FSH showing absolutely no difference in the final cumulative live birth rate for these poor responders. So there's no point in going beyond 375 or 450 for most of the Poseidons 3 and 4. And coming to my favorite subject, and that is LH supplementation. Remember that in women of advanced age, with age, there are less functional LH receptors, less potent and biologically active endogenous LH, and there are low levels of circulating androgens. What about your agonist and antagonist protocols? Why do you need to supplement LH, and why do I keep telling you to add LH? Very simple. Again, go back to Spiroff. Compare a natural menstrual cycle versus a stimulation cycle. So let's look at all the three. First being the agonist long protocol. You can, as I told you earlier, your LH levels are 0 because of the complete downregulation, desensitization, and complete blockage of endogenous LH. Some of you would argue that's good. We don't want LH. How would it affect the results? Number 2, look at the antagonist. You have a good baseline LH at 5 MIU per ml. And once you begin the antagonist, you have severe suppression. Then you have a good recovery. You have suppression, good recovery, suppression, good recovery. But look at the natural cycle. Your baseline LH, of course, would be the same as the antagonist cycle till you add the antagonist. And after that, your LH levels start rising, as you can see here, till you get your mid-cycle peak. So how unphysiological are we getting with the agonist and antagonist? And just looking at this slide will tell you why addition of LH to at least have this much of LH in your agonist cycle or this much of LH in your antagonist cycle is so important. So you can see here in stimulated IVF, the LH levels are always much lower than a natural cycle IVF as shown by Wolf way back in 2014. So which all patients need LH? All women above the age of 35, all your hypo responders. Now, who are hypo responders? They are usually the patients who are carriers of polymorphisms. So they have stagnant follicles after a particular stage, and you just go on pumping in FSH and they don't increase the size of the follicles. All your patients with hypo, I actually wait for this group of patients because they're easiest to treat if you dose them correctly. And the commonest mistake made, people give 150 of HMG, 5 days, no response, go for egg donation. 225, no response, go for egg donation. They will not respond to these doses. They have zero endogenous FSH LH. The minimum starting dose for a hypo is 300 of simple urinary HMG. So you need 300 of FSH and 300 of LH, and it will be miraculous the way on day 7 or day 8 you will see 10 to 20 follicles. You don't have to give the antagonist, you don't have to downregulate, you cannot use the agonist trigger, you have to give her an HCG trigger because she has no endogenous FSH LH. And they have wonderful egg quality. So that is the very heartening part of these patients. They look very difficult to treat, but the egg quality is so good that most of them conceive in the first or second frozen embryo transfer. All Poseidon groups, of course, need LH irrespective of 1, 2, 3, 4. And I'll show you evidence that why even PMOS patients should be given LH from the beginning. So we have all these meta-analyses clearly showing that addition of LH will improve the response in hypo responders, and LH supplementation is more efficient than just going on increasing your FSH doses. So this is very important. Again, in India, there is a tendency that we start with FSH from day 2. And on day 7, we switch to HMG, thinking that, okay, this will bring down cost, this will give her some LH, and this will give her better outcome. But please remember, we now have studies clearly showing, comparing early follicular HMG, means giving HMG from day 2, some LH from day 2, versus adding LH from day 7. And you can see live birth rate from day 2 is 22%. If you add on day 7, it drops to just about 12%. So all these are very important fine-tuning points for you to improve your results. Which LH to use? Of course, I don't favor one company over the other, but it's a personal preference that I like to use HP-HMG where there is HCG-driven LH activity rather than just pituitary LH or native LH, because HCG has a longer half-life. It tends to accumulate, whereas native LH is washed out of the system in just a few hours and does not have a 24-hour effect as you would get with a HCG-driven LH activity. So there are studies to show that the higher the HCG level on day 6, the greater the proportion of top quality embryos that you have. And therefore, you can see here when you just give LH, your live birth rate, if it is say around 10%, because there is no accumulation of LH, you have to give it on a daily basis. But when you use HCG-driven LH activity, you can see a huge increase in your live birth rates just because of the accumulation of HCG and the better effects of LH on aromatization and estrogenization and all the other factors that give you a successful implantation. What about more recent evidence? Of course, this was the latest study by Philo in 2024, where whether addition of 150 IU HP-HMG, if combined with REC-FSH, improves your response. And as you can see here, better estradiol levels, higher fertilization rates, higher number of blastocysts available for transfer, all statistically very significant when HP-HMG is added right from the beginning of stimulation for these patients. And an even larger study of 12,000 cycles from 2025, 6,000 patients receiving LH, 5,000 receiving FSH alone, and clearly the LH group did much better and had much better cumulative live birth rates. Dual stimulation, of course, it's out. I stopped doing it within a couple of years of starting doing it because we had got it wrong all along. We were not doing a real luteal phase stimulation because, you know, the agonist trigger was given in the follicular phase. And then within 4 days, we would start another stimulation saying this is luteal phase. Even if the patient had menstruated, we were still calling it the luteal phase. So remember, when you give an agonist trigger in the follicular phase, you have abrupt luteolysis. If you were to just check the estradiol progesterone levels on day 2 of that so-called luteal phase, you will see they are estradiol less than 50, progesterone less than 0.5 like day 2 of a follicular phase, and you don't have a progesterone level of 3, 4, or 5 like a luteal phase. So we were just doing 2 back-to-back follicular phase stimulations. This will be the correct way of doing the dual stimulation, which we are expecting Annalisa Raka and Nicholas Polizos to present at the London ESHRE. The first stimulation will begin in the luteal phase. You document ovulation, begin FSH, add antagonist, give the agonist trigger, pick up, wait for day 2, do a conventional cycle, again add the antagonist, give the HCG trigger, and then do a fresh embryo transfer using whichever embryos were of a better quality. So it would be interesting to wait and see how the results are. But at present, the reality, comparing dual stimulation to doing 2 conventional stimulation cycles back to back, if you want to really know what was the outcome of these 2 analyses, I'm sure all of you are guessing, but Masin in 2023 clearly showed when you do 2 conventional cycles back to back, as compared to dual stimulation, your cumulative live birth rate is double. So what is the logic, therefore, of pumping her with injections for 28 days with the so-called point of trying to exploit 2 menstrual waves of follicular recruitment, or 3 waves of follicular recruitment in a single menstrual cycle? Number of metaphase 2s were also comparable, and Cerillo in 2024 again did a wonderful comparative study showing higher cumulative live birth rate with 2 conventional stimulation cycles as against dual stimulation. And also the number of metaphase 2s in his study were significantly higher. I was really happy with ESHRE 2025 at Paris because they clearly showed that letrozole and clomiphene should not be added for high, normal, or low responders. So any group of patients doesn't need addition of letrozole and clomiphene. A lot of you might disagree because we are so used to giving letrozole for poor responders or clomiphene and so on, but the evidence is not supportive. And the second, which I really feel so good about, that finally I got some validation after 25, 30 years of saying this. In my entire 35 years of practice, I have never done any hormone estimations. So it's just an AMH level before I start and the beta HCG to confirm pregnancy. Only recently, past 2-3 years, when we started rejuvenating fresh transfers, I do 1 serum progesterone level on the day of HCG to see if I can go ahead with a fresh transfer. If it's between 0.5 and 1.5 or 2, fresh transfer should give you the same result as a frozen. Any other low or high level of progesterone would not be useful. So we now clearly have guidelines that hormonal monitoring during ovarian stimulation has limited or no value, and it is not required to be done. Moving on to rejuvenation procedures, of course, I want to give you a word of caution because we have a lot of talk about intraovarian PRP. We know that it is probably just the needling that we do, the mechanical effect that works, and not actually the PRP. But of course, all these things are debatable. We also have autologous stem cell transplantation. We have 3-parent IVF, mitochondrial transfers. Collectively, these are all known as augment procedures or ovarian rejuvenation. So Kakiroglu in 22 showed that with PRP, he got better number of mature oocytes, and especially in your young poor responders, he showed a good 34% live birth rate. Of course, the elderly woman above age of 38 did not do too well with just 8.7 live birth rate. But subsequently, we don't have any solid RCTs to corroborate these findings. And the only real RCT we have is the PROVA trial from Sweden, where they clearly showed no significant benefit of PRP as far as oocytes, blastocysts, euploid embryos, or implantation was concerned. We then had Velasco Fertility Sterility 2025, again showing oocyte and embryo yields did not increase, and more prospective RCTs are recommended. Aguirre in 2024 again addressed the question, does intraovarian PRP increase the number of retrieved oocytes? He said neither improvement in euploid blastocyst development nor pregnancy rates have been demonstrated. So at present, all these procedures remain experimental. They may be drawn to this promise of rejuvenation, but available data does not show any improvement in outcomes. Please remember, balanced counseling is required to avoid raising unrealistic expectations, and most importantly, to ensure that patients are not diverted from established, more effective options such as oocyte donation. So these false rays of hopes may set her back. She will do an intraovarian PRP, and then she will again try to a couple of cycles, and she will waste another 6 months to 1 year and just keep delaying the chance of achieving a live birth. Finally, of course, we have to talk a little bit about PMOS, and I say little bit because there's not much to talk about PMOS as far as stimulation is concerned. We all know that we have a wonderful 3 musketeer approach now, which I'll show you, which all of you are familiar. That is, you have to use the antagonist, you have to give the agonist trigger, and you have to do a freeze all. So it's almost a no-brainer now that when you see a thin, lean, or a high BMI PMOS patient, you just have to use these three things to ensure that you are a OHSS-free clinic and you get the best outcome for these patients. But what's new? The GLP-1 receptor agonists, we have been using it for a lot of our high BMI PCOS patients, sorry, PMOS, and we know that they are really wonderful drugs for this group of patients. Current consensus, we know that short-term use of these products can cause significant improvements in insulin sensitivity, ovulatory response, and fertility outcomes. And fortunately, we know that inadvertent early pregnancy exposure to these agonists does not necessarily result in any adverse neonatal outcomes. So that is very good to know. In fact, Salamun, he gave liraglutide with metformin and allowed the patients to conceive naturally and found a very high cumulative pregnancy rate over 12 months in women with PMOS undergoing IVF. So of course, I am not giving you a take-home message that, oh, put everybody on tirzepatide and Ozempic and let them conceive or do your IVFs. As of now, we know that if she's on Ozempic, you have to stop for 2 months. If she's on tirzepatide or Mounjaro, you have to stop for 1 month before you do the IVF cycle, until we have more clinical studies on the short and long-term neonatal and infant effects of these particular molecules. What about OC pill pre-treatment? It's quite fashionable that the minute you see a PCO patient, oh, she must be having high LH on day 2, so I need to put her on the OC pill as pre-treatment. And a wonderful study to put all these doubts to rest by Zhu in 2024. 2 arms, one where OC pill was given to reduce day 2 LH levels before starting stimulation. The other group where stimulation was started irrespective of high LH levels. And of course, he gave a mandatory 7-day washout period in the OC pill group. And as you probably guessed, the study showed that high LH levels on day 2 did not have any obvious negative impact on embryo quality. So please feel safe, feel rest assured. You don't need to give her the OC pills to reduce her day 2 LH levels. In fact, you will cause her harm because, as I'll show you subsequently, you will suppress the endogenous LH so much that your agonist trigger will be rendered ineffective. I told you earlier also, for the agonist trigger to work, you need a good stock of endogenous FSH and LH. Only then will you get a good conversion to metaphase 2 oocytes. So of course, as I told you, stimulation for PCO has become too easy. Even if you have 70, 80, 100 oocytes, agonist trigger, nothing happens. The patient is absolutely back to normal the next day. You don't need to give any prophylactic albumins. If at all you're worried about the high estradiol levels, just letrozole 5 milligrams for 5 days, or maybe a little bit of Caberlin, and that's all you need to give to make sure that the ovaries quickly shrink back to normal size. And this is what I was telling you here, that the more the suppression of LH because of OC pills in PMOS patients, almost 40 to 50% of your patients will give a suboptimal response. And it is so classic that you give the agonist trigger and you get so many empty follicles, you get less oocytes, you see 40 follicles and you just end up with 10 oocytes, very few metaphase 2 oocytes, and a disastrous outcome because of the OC pill pre-treatment. In fact, even with egg donors, be careful. A lot of them might be on OC pills and they withdraw and come for the stimulation. So be very careful that you make sure that she has not taken any birth control pill in the preceding cycle. Otherwise, you will not get a good crop of oocytes in these patients. Addition of LH in PMOS patients. Of course, some of you may be familiar with the Megaset HR trial, which compared HPHMG with HCG-driven activity versus REC-FSH. Fresh cycle outcomes were comparable, but what was really noteworthy, the early pregnancy loss went down from 24 to 14%. When they looked at the FET outcomes, they again found non-inferiority. In fact, they found higher pregnancy rates in the HP-HMG group. Once again, early pregnancy losses were down from 26 to 14%, because despite our 3 musketeer approach, we are still plagued with a higher early pregnancy loss rate in our PMOS patients. And this is probably one way of reducing that. And what HP-HMG, especially the HCG-driven LH activity, does is not restore euploidy, as this study showed, but does something to the cytoplasm and the mitochondria and the overall integrity of the PMOS oocyte, which helps to reduce early pregnancy losses. And why do we say this? You can see here the cumulative live birth rate with all transfers done over a 6-month period was similar in both the arms, but achieved with 43 fewer embryo transfer procedures in the HP-HMG group most importantly, using 65 less euploid blastocysts. So all the frozen transfers were done on PGT tested euploid blastocysts, and yet you found a reduction in the early pregnancy loss rate, and you found a cumulative live birth rate which was achieved using fewer embryos and fewer procedures with the HP-HMG. So at my clinic, at least, I like to add 75 of HP-HMG from day 2 for all PMOS patients. PPOS, is it the end of the road for the antagonist for your high responder group? Again, of course, we had Chen's wonderful study in 22 who actually showed higher clinical pregnancy rates with PPOS generated embryos as against antagonist generated embryos. But subsequently, we don't have too many studies corroborating the same, but at least it seems to be on par. We also have studies showing that whether you give 10 milligrams or 2.5 of MPA, if you use 20 of dydrogesterone, if you use 100 or 200 of MVP, or even if you give just one tablet of micronized 200 milligrams orally, it is enough to suppress the endogenous LH surge. So maybe you could use it for all your freeze-all patients, PGTs, endometriosis, and high responders. A word of caution, because today, of course, we don't have that much time. But the most important, there is a new study where they assessed and compared euploidy rates between PPOS generated embryos and antagonist generated embryos, especially in women above the age of 35. So remember that these women of advanced age, the oocytes may not be able to withstand synthetic progesterone exposure in the follicular phase as well as young oocytes would. And therefore, a word of caution that if you are treating a PMOS patient above the age of 35, maybe it would be wise to stick to the antagonist and not use synthetic progesterones, which could reduce euploidy rates. In fact, that study showed a reduction of euploidy rate from 30% with antagonist to just 6% with PPOS in women of advanced age. So it's very important to keep this in mind and don't just blindly keep switching your protocols without a detailed study of all the available literature. Finally, of course, before I go, leaving you with something to reduce your miscarriage rates in PMOS patients further, we all use myoinositol, we give coenzyme Q, we give probiotics, we use HP-HMG from the beginning, but yet we have early pregnancy losses. So do we have something new? And this is where Itakura's presentation at both ISAR and IFS last year in person, he was there, but I'm sure a lot of you missed this particular presentation. Simple FSH 150 from day 2, switch to HMG 150 from day 7. Antagonist not added at 14 mm, but when the leading follicle reached 18 mm. Agonist trigger not at 18 mm, but when the largest follicle crossed 24 mm. So delayed triggering to give it the full kind of development that you would get in a normal 70-day follicular phase of a normal menstrual cycle rather than just 9 or 10 days. 1 tablet of letrozole, if E2 level was 4,000 to 5,000. 2 tablets, if E2 level was more than 5,000 on the day of the trigger. And you can clearly see with this modified protocol, he compared it to the agonist, the antag with HCG trigger and the antag with agonist trigger. Live birth rates up from 18, 27, 25 to 36%. Miscarriage rates down from 24, 29, 30 to 19%. Cumulative live birth rate from 30, 38, 37 to an astounding 57%. So there is definitely something here which needs to be followed up, something where we need to see if we are able to duplicate the same results. So to conclude, of course, one protocol will never fit all. And I told you, you have to do so much of individualization nowadays, especially clinics like ours, where almost 90% of patients are those who have failed not one, but multiple IVF cycles in some center from somewhere in the world. So we have to pay a lot of attention to these patients, not only for stimulation, but also for transfer. High responders, antagonist protocol is mandatory, agonist and freeze-all. Normal responders, try to use the antagonist with pre-treatment for the first cycle, because sometimes a normal responder can have OHSS if you directly use the agonist. If, say, with the antagonist, she gives you 8 or 10 or 12 or 15 oocytes and it fails, you could consider the agonist for the second cycle and try to maintain your 2:1 or 3:1 ratio of FSH-LH. Low prognosis patients, my personal choice is agonist with simple urinary HMG 300 or 450 in the first cycle. If that fails, we switch to the antagonist again with a combination of FSH and 150 LH from the beginning for the second cycle. So once again, thank you so much, Monica, and your entire team Synergy. Thank you, ladies and gentlemen, for giving me such a patient hearing. Thank you so much.
Mm.
Thank you, Jatin. Thank you.
Jatin sir, my brain is going to burst.
Hey, what happened?
Jatin sir, we are looking and we are listening you since last 30 years, and we both admire you. And just I saw I was reading your slides. You're updating every moment, sir, every month, week and month. Great. Sir.
Every day.
So as you take, I'll inform to everybody. He's a very perfect photographer. I think he should get the Guinness World Record for photography.
Thank
So
you.
in the ovulation, you are now taking the photograph of each follicle inside. What is going to happen?
So, Jatin sir, it was really a very mesmerizing lecture. And what is your what are you looking forward to in ESHRE of London this year? What are the trials?
AI,
in
where
your
AI is going to help us. I think there's 1.5 days of sessions only on AI for sperm selection, embryo selection, protocol selection, day of triggering. Everything is going to be AI based algorithms based on data from 30, 40, 50,000 cycles. So it sounds interesting on paper, but I'm looking forward to actually hearing the presentations. That would be one real important area. Secondly, a lot of gray areas around the routine practice of PGTA. So that will be again corroborating what I keep saying, that don't try to do PGTA is not the solution for everything, every problem that you have in IVF, and it may actually reduce pregnancy rates. And there was an article just 2 weeks ago by Wiseman and Gleicher, actually saying that PGT is not good and reduces the success rates and live birth rates. So we need to do a lot of rethink on a lot of add-ons. So they hopefully should be interesting. Of course, every year we come back thinking there's nothing new, but if you really go through all the sessions, all the posters, all the papers, come back and then go to the ESHRE. They have these workrooms and classrooms, where you can keep hearing all the lectures again and again. You definitely pick up a lot of points there.
Thank you, sir. And sir, considering that most of your practice is made up of Poseidon 3 and 4, is it?
Maximum Poseidon 3 and 4, yes.
Yes,
Like
sir.
every day, if I have say 8 to 10 egg pickups, at least 5 of them will have less than 5 eggs. So those are usually the Poseidon 3 and 4. And then there'll be 1 or 2 PMOSs and there'll be just 1 or 2 normal responders. So that is the normal ratio that we have.
What's the amount of PGT you do? What is
Very
the
few, very few. Hardly 7 to 8% of my patients.
right?
So that's a wonderful article. You must go through Gleicher and Wiseman's article. And you should also, there was a paper at Amsterdam, when we had ESHRE Amsterdam 3 years ago, there was a doctor from Netherlands. Because everybody is fed up everywhere. Every patient is saying, oh, why you're not doing PGT? Why you're not doing PGT? So he compared practice between US, UK and Netherlands. And he showed, it was a keynote address with 5,000 people in the main hall, that in US, 60% of cycles they do IVF. Now, considering that all 3 countries have a similar proportion of white Caucasian, black African, Indian, Japanese, Pakistani, everything is similar in all 3 countries, then if it's a medically indicated procedure, the proportion of patients requiring it should be similar too. So US, 60% PGT is done. UK, it's only 7%. And Netherlands, he said 0%. Okay? Even 43-year-old, we don't do PGT. So, this is the kind of difference we are having in PGT practice everywhere. So somehow in India, too many of us picked up too much of PGT too soon, and we need to rethink because, it sometimes reduces the pregnancy rates, and we should not take for granted that, oh, PGT is the final answer. Because when does trouble start? When you do a euploid blastocyst, telling the patient it will reduce your miscarriage rate, a 40-year-old, and she again has a miscarriage, and then to answer, and then you say, oh, it must be mitochondria, must be cytoplasm, must be aging of the oocyte, must be non-genetic reasons. It puts you in a very, very awkward situation. So we have to be very careful. And there are a lot of lawsuits happening in the US right now on PGTA. So please, everybody be very careful where we apply, where we don't apply. The ART Act also tells us, has laid down indications where PGT should be done. So it's not some kind of magic wand to get everybody pregnant,
So
Yes, sir. Because last day, yesterday, I think this is why we have chosen this today, because the last day, 30th was the last day for submitting the ART cycles and all. And initially now at this time, they have not asked the window of PGT, but you're right, sir. It's unnecessary. We are doing too much PGT in India also.
Yeah, too much.
So, sir, you mean to say the miscarriage rate increased by PGT is due to the mechanical aspect of doing the PGT or the post-PGT embryo? What?
Mechanical, and see, there is a wonderful paper by Alviji, Laura Renzi, and Carlos the Velasco, three of them, opening the black box of implantation, why PGT does not work. And they have analyzed 800 papers, every possible paper on PGT, and they have shown PGT cannot compensate for advanced age, cannot compensate if the initial morphological grading of the embryo is not good, and cannot compensate for RIF. They have clearly concluded that these three categories where we keep applying PGT don't really benefit with PGT. So everybody must read that paper. It's a fantastic paper opening the black box of implantation, why euploid blastocysts fail to implant. That is the heading of the paper.
Sir, nowadays, so many of young specialists, IVF specialists are just going to freeze all. You know, it's more convenient. Frozen
Yeah.
embryo transfers is fashionable. It is easy. So what percent, since you're saying PMOS and normal responders form a lesser chunk of your practice as compared to Poseidon 3 and 4, how many of your percentage of your cases are freeze-on and how many are fresh?
So right now we are doing fresh transfers, for all poor responders who give less than 10 oocytes. If the endometrium is a good triple line, if she's on a long agonist cycle, if the progesterone on day of HCG is between 0.5 and 2, we go ahead with a fresh transfer. Fantastic pregnancy rate, ongoing pregnancy rate of 32%, which is very good for that particular group of poor responders. And more importantly, you will say, okay, how does it make a difference? Our clinic is used to freeze-all. It is the same results. It's not the same. There is a study by V from 2025, WEI, 2025, 850 women of poor prognosis. He has shown 5% higher pregnancy rate with fresh versus frozen, 8% lower early pregnancy loss with fresh versus frozen, 30% lower first trimester bleeding with fresh versus frozen. So everything, cumulative live birth rate 6% higher with fresh versus frozen. So now it's not on par. Statistically significant higher pregnancy rates with fresh versus frozen for two categories of patients. One is your poor ovarian reserve, low AMH, low FC patients. And even there is a study by Wu from 2025 that women of advanced age, 35 to 40, there is a 5% higher pregnancy rate with fresh transfers. And these are studies of 2,000, 3,000 patients. They are not studies of 40 patients. So, of course, I have a whole lecture on that, which I have been giving recently everywhere. Fresh versus frozen, natural versus HRT. So, our HRT FET cycles have gone down now to almost just 20%. If I am in town for the entire month and not traveling, 70-80% of patients are on true natural cycle transfers, and they really appreciate it because they are not on all the painful medication that we give. And the dropout rate reduces when you don't give HRT, because if you ask a patient, why did you drop out? Okay, finance is one issue. The second commonest reason for dropout is the burden of medication that we give in the HRT cycle. With all our heparins, aspirins, intramuscular progesterones, vaginal progesterone, dydrogesterone, aspirin, sildenafil, you just look at the prescriptions, patients go crazy with that, They don't mind the stimulation. They don't mind the anesthesia, but they're really fed up of this HRT FET.
So in your true natural cycle, do you use letrozole or you just...
Oh, then it's not called natural cycle. True natural is natural. Zero medicine, zero. If at all my son feels, he will give one gel vaginally. That's all. Nothing more.
Right. And you wait for the ovulation to happen?
Yeah. So there are more visits required. So you can generally do it for local patients only. But nowadays we have allowed, even the outstation, because 50% of my patients are from outside. So we let them do it with a reliable radiologist. Then we confirm with E2 and progesterone levels if required that she's ovulated once he says rupture. And the best part is that we consider that, there is a very narrow window of implantation, which is not true for the human species. Human beings have the largest window of implantation compared to all animals. And this was a wonderful study from 1996, Harper's study, actually studying that what is the window of implantation. So even if she say ruptures on Sunday evening, she comes to you on Monday morning and says, doctor, and Saturday morning you scanned, she was 22 mm. Sunday evening, she feels the pain. Monday morning, she comes, you see the follicle has collapsed. You can still count Monday as day 0 if you want to do a blastocyst transfer on day 5, right? You don't have to count Sunday as day 0. So this 24-hour window is what most people forget that humans have. And we keep worrying that, you have to, how to time it? I only have a 4-hour window, 6-hour window. It's not a 4 to 6-hour window. It's a 36-hour window.
So you don't give her progesterone?
No, nothing. Natural is natural. Then modified natural cycle, you can add a gel or you can give the HCG trigger. And for PMOS, you can do letrozole HMG, what you saw in the IUI lecture, you can do that. So you have to give them a corpus luteum in early pregnancy. That is the message for the day. HRT, FET, there is no corpus luteum. And it's not just PIH, it's everything else. If you hear that lecture of mine on transfers, main thing is in HRT, FET, all of you would agree that 4 out of 10 have first trimester bleeding. Despite your high progesterones and dihydrogesterones and everything, 4 out of 10 will call you that doc, I had bleeding. In natural cycle, when you have a corpus luteum, that goes down to 11%. Only 1 in 10 will call you for bleeding.
So when are you writing your textbook, Jatin sir? Anna, people will stop reading Spirov.
So yes, sir. So you are so encyclopedia, sir. You are the great.
So you have to, because see, when you deal with just failed cases, all your mind
Yes,
starts working in all directions because you have to
Yes.
think different. If I'm going to repeat the same protocol, how am I going to get a different outcome? It's going to be the same failure again, right?
Yes, sir. I remember you called me that one patient did 3 or 4 times surrogacy with you, and still she wanted a surrogate at your center.
Yeah.
Sir, you have been repeatedly talking about HCG-driven LH activity
Yeah.
in your HMG.
Yeah.
So there is only one brand which
No,
delivers.
that international brand is one, and we have 2 Indian brands now,
Can
which
you
are
tell-
equally effective. I can't name on the panel, but I'll
Yeah,
message.
we can message and we'll put it in the group for the benefit of our
Yeah.
audience because the international brand is sometimes too expensive for.
I know. So we have also started using the Indian one, and it's really good. Really, really good.
So Aparna, I can see Aparna Virul is there, and so many other IVF specialists, ART practitioners. If you have any questions before Jatin sir signs off, please unmute and ask your question to Jatin sir.
Because you are in the front of the best person. I salute him, the best knowledge person in the IVF you are now at present in the world.
Thank you so much, Jatin sir, for clearing our doubts. And Dr. Pratik is there. We will now grill him with the IUI questions.
Thank you once again, Team Synergy. Thank you, Monica. Thank you, Randhir.
Thank you, sir.
Hi, Rama.
So any
Thank you, sir.
questions from the audience? Any questions from the audience for Jatin sir? Sir, we will be messaging you with a couple of questions. Do respond on WhatsApp and then
Yeah,
we can
sure.
ask the answers to. Preeti, are you asking something? Okay.
Oh, hi, Preeti. I didn't see Preeti. She has the ceiling behind her. No, San Francisco.
Yes, Golden Gate Bridge. So thank you so much, Jatin sir. It was mesmerizing like always. And every time I have got so many questions written for you on these papers, but the time is too less.
Yeah.
And thank you for everything. Thank you for being there. Thank you, sir.
Thank you so much, Jatin sir.
Thank you.
And now we have got Pratik sir. We listened to wonderful lecture by Pratik sir on IUI. So IUI seems to be a simple procedure, but he has talked about a case where this couple underwent 25 IUI cycles. So that was, I
Which
must
was
say
of their own volition, of their own choosing.
Yes.
So don't blame the doctors.
No.
Yeah, but
Do not blame
Pratik,
the
when
specialists who treated them.
yeah. But Pratik, when we started practice, we used to get that in 2 numbers, 2 digit, 10 plus. But 25 is the first time, really.
Yes, I
So
have
this happened to me about 15 years back. And that was something which just came to me, I keep remembering that couple every few months, whenever I get couples who have done more than 5-6 cycles, because they really deserve a Guinness Book of World Records.
So the audience, I would like to say that Dr. Pratik Tambe has joined us exclusively for the Q&A session. So if any doubts related to any aspect of IUI or any other question you have for Dr. Pratik, because he is again an encyclopedia for ART, you are most welcome to unmute and ask the question directly from Dr. Pratik sir. And
Yeah.
Dr. Pratik, I'll start with the first question. You talked about in the pre-IUI counseling, you talked about rubella vaccination. So do you ask for the history of rubella vaccination to every patient who comes to you for IUI?
This is part of the standard questionnaire that we have. In the old days, I used to take the histories personally. Sometimes it's cumbersome when you have a lot of patients, and that works for most of us now in clinical practice. So there's a simple checklist, and this is one of the check boxes, whether you've received the MMR vaccine. If for some reason they say that they have not received it, then any which ways, even if they neglect to ask that question or it gets missed out during your tick, 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 you always do a rubella IgG on paper and document that it is positive. The moment it is negative, you have to advise and you have to counsel for the vaccination, give them a 3-month break, and then give them active fertility treatment. That is just common sense. It's part of the RCOG guidelines. And this is more relevant in Western countries where you have this strong dominant force of anti-vaxxer. You know, I have one hand holding up the phone, otherwise I would do the double tick and the double quotes with both my hands. These anti-vaxxers are responsible for driving a big chunk of normal human beings away from vaccination, which is why there are measles epidemics which are happening in Western countries, especially the UK, which we all diligently follow. This may also be a condition here in India amongst the well-educated set who are Insta savvy, etc. It's always good to have a rubella IgG on paper as positive to protect yourself if nothing else.
Yes, you are very right about these anti-vaxxers. The term I've heard first time, but there's a special group who would like to deliver in the wild. You know, the women have died. They don't want any obstetric facility.
So in case you're unaware and if your audience is unaware, the current health secretary for the US, Robert F. Kennedy, is himself an anti-vaxxer. And one of the first things that he did when he came into office was to chuck out the head of the CDC and install his whole team. And his own team, when it came in, it struck down a lot of the vaccine recommendations, just like we in India have the expanded program and immunization, EPI, which is universal for all children who are born in this country. They have a similar program in the US, which was completely overturned by. That's a different controversy altogether. So I don't want to go offshoot now.
Yeah, since we are in the Q&A and we have got liberty of talking on synergy, so sometimes I divert. So I think it really it stands for the more advanced we get, more developed we get, sometimes our mind starts going the reverse way. And another thing I wanted to ask was any possibility, any experience you have with dual trigger in IUI in those cases where the follicles formed are about 3 to 4 and the patient is insisting for a trigger and she wants an IUI. The follicles are 3 to 4, mature follicles. Any possibility of giving a dual trigger and preventing the possibility of OHSS using very less dose of HCG for it?
So when this entire concept of GnRH agonist trigger came in, I'll be honest and say that there were many youngsters. This was around 2010, 2012, if I'm not mistaken, who completely stopped giving the HCG trigger and switched over only to the GnRH agonist trigger in IUI cycles. We're not talking about IVF here. And after 6 months, they found that the results were quite sad and poor. Ovulation was happening. The IUIs were smooth, everything was fine. The inseminations were not the issue. The TMSE was not the problem. But somehow the results had dropped. And when they went back to HCG, they found that the results picked up again. Now, this is something which is completely unexplainable. It's not part of standard literature. I have not seen any papers which reference this. But I personally also went through that phase. So I switched over back into pure HCG. And since then, I have never had a reason to think of dual trigger for IUI cycles at least.
There are many people who think rec HCG is better than urinary HCG. What is your personal opinion?
That was in the good old days, 20, 25 years back, when we used to have very poor cold chain maintenance, and especially the stockists. Just like I said, gynecologists came in 2 different species. One was the general gynecologist, one was the IVF specialist. Similarly, the stockists were also 2 different species. One was to be favored by the international companies like Merck Serono, like MSD, and those stockists had very good quality control. They needed to maintain cold chain, they needed to maintain good records and documentation of their temperature control because that was required by those companies. Whereas the Indian companies were much more flexible. So sometimes those stockists used to just switch off the refrigerator at night. And that is what led to the errors in cold chain maintenance. And therefore, in those days, in that scenario, we used to feel that maybe the Indian companies or just the HP HCG which we got was not as good as the REC HCG. Today, I think they're pretty much equivalent.
So
It's not so much of an issue in today's world.
what is your recommendation of the HCG trigger dose? 5K or 10K?
I usually give 10K to everybody.
Right. And there is a
I've always given 10K, but there are very good papers which say that 5,000 is also good enough. It's absolutely fine. And the recombinant HCG 250 micrograms Ovitriol that we give is works out to about 6,750 if I'm not mistaken.
Yes, because the LH surge which they cause is going to be the same, whether it's 5K or 7,500.
Pretty much.
There is something called a 7.5K HCG also available.
And there are some people who use 5,000 from two different manufacturers, from two different stockists, but let's not go there.
Yes, that is a like
Desi jugaad, so to speak.
Indian jugaad.
Yeah. So be sure that एक खराब है तो एक अच्छा रहेगा.
हाँ. So there is
दोनों में से एक तो काम कर लेगा.
And Dr. Pratik, there is a preparation of HCG which is available in the liquid form. I personally think I'm also the same era of practice as you. I feel that lyophilized retains its potency better because you're going to reconstitute it in front of yourself. Your staff is going to administer there and then. What about the preparation of HCG which is available in the liquid form? Certain brands.
If it is something which is a pre-filled syringe for ease of administration for patients at home at a time and place of their choosing for convenience sake, then I'm all for it. But in most cases, I feel that I would concur with what you say, that the old ways are still quite relevant and applicable.
So that brings me to the end of my questions. My
audience. Yeah. We request other audience to go. Meanwhile, I can ask one question, Pratik. What is the lowest count, effective count after wash, semen wash for minimum for a good IUI results?
So in theory, it is 1 million.
Therefore, I asked whether it's theory or practical.
In clinical practice, you need at least 2.5 million.
Yes.
Anything less than that, your results are going to be quite sad. And any which ways, once you see a TMSC like that, you need to sit and talk to the couple after you've done the insemination, that we have done it in good faith. Results are likely to be poor. Be mentally prepared that we will have to fast track you to ICSI.
Sir, I want to ask one question.
The counseling is very important because they are at a very sensitive and vulnerable point in the entire cycle. And when you can show them the actual sperm count live, if you have the facilities for doing that and your embryologist does that, then they are even more convinced.
Yeah, I totally agree with you. When you show the real count as today, it's not very easy just to make the film and give WhatsApp them. The patients are very, very satisfied, very much.
Exactly.
Yes, ma'am, you're asking some question?
Good evening, sir. Sir, I just want to know, sir, if there is spontaneous rupture of follicles before administering HCG and patient is not willing for the same day or next day IUI, he is asking me ki day after tomorrow, can we plan? Sir, is it worthwhile to plan IUI?
So usually in the initial counseling itself, we counsel couples that when the ovulation takes place, typically the oocyte is supposed to be at its most fertile in the first 24 to 36 hours. That is why we time the ovulation, and that is why we time the trigger and the insemination procedure. If you exceed those limits, you may still get results. But then again, for a procedure as it is, which is going to give you 7-10% results, in the best of hands at the best of times, you're just wasting one cycle. And as you know, they have a very finite number of cycles. 2, maximum 3 cycles is what couples will come to you with in today's world. In major metros, like I said, I'm lucky if I see a patient for a second cycle, they usually go somewhere else because they have so much freedom of choice in today's world. And of course, there are plenty of people who will keep giving them, what I call little nudges like go to XYZ, go to ABC, so on and so forth.
Right, please.
All due respect.
Okay. Thank you.
Thank you so much, Dr. Pratik. And thank you for the lecture. Thank you for the recording you did for us. And thank you for the Q&A session. Any other question? Otherwise, we can wind up and
I think I'm holding up the panel, so I'll wish Monica all the very best for her elections.
thank you so
I
much.
hope to see you as a Foxy Committee chairperson very soon, and I think you're part of the MP-SR hierarchy already. Look forward to a good showing at the elections for you. Thank you very much for having me here, and thank you to the entire Synergy team for inviting me. Apologies for the poor quality of the audio video. I'm traveling, so it may not be up to the mark.
Thank you so much, Dr.
Thank you.
Pratik.
Thank you, Pratik. Thank you, Dr. Pratik.
We'll be sharing your lecture with all the audience for later viewing also, because though the audio was a little bit of disturbance, but the slides were really good and we could read everything and understand everything. Thank you so much for your time, and you're doing wonderful.
Thank you. All the best.
Thank you. Thank you. And now it is my pleasant duty to welcome amongst us our guest of honor, Dr. Ajay Mane sir. Dr. Ajay Mane sir has joined.
बस we'll skip that मोनिका दीदी will skip
नहीं
that.
सर नहीं सर
अरे नहीं
दो
रणधीर
शब्द
भाई
तो बोलने पड़ेंगे सर
नहीं इतना
वेलकम
अरे
वेलकम सर वेलकम
सुनिए
सर वेलकम
नहीं सुनिए इतना वो बोल सकते हैं पर इतना साइंटिफिक चल रहा है कि मुझे मेरा नाम भी बीच में डालना ऐसा लग रहा है कि वी आर disturbing the quorum. So to start with, I must congratulate Monica Didi and Randhir Bhai, then Virul and Dr. Purva for conducting such a beautiful program. And I am remembering my training days. In 1998, I was student of Firoza Parikh in Jaslok Hospital in Wadia. And I remembered that those days. And Jatin sir was at par. वो तो चांद पे लेके गए हम सबको तो. Very बढ़िया. I am waiting for the lecture of Jatin sir on my failed cases.
Okay.
Just after that, no, I am waiting. Yes. Please, you request him.
Yes, sir. We'll arrange, sir. Mane sir will arrange next time. Yes,
that will be the best book than anything.
Best.
Yes. Perfect. And I specifically congratulate Monica ma'am, and I urge to all that she must go to Foxy as a chairperson. I request everybody to kindly vote for my sister, and you make your friends also to vote her. Okay? And we all are with you, Monica Didi, and you are there for sure, 100%. So best luck for the Synergy 33. Today is Doctor's Day. I wish every doctor the success and peace in their practice, because आजकल पेशेंट बहुत मारते हैं, पर मैं भगवान से प्रार्थना करूंगा कि वो ना मारे और हम पे फेथ रखे कि चलो ठीक है कर रहे जो अच्छा कर रहे. ठीक है. सो डॉक्टर्स डे की बहुत सारी शुभकामनाएं. एंड मोनिका दीदी आपको फिर से एक बार शुभकामनाएं हमारी सब की तरफ से और मेरी तरफ से. थैंक यू फॉर कॉलिंग मी हियर एंड प्लीज कंटिन्यू विद द एकेडमिक सेशन. आई एम लिसनिंग.
Want to just one thing. Ajay Mane sir is my brother. He is my mentor, and we did a beautiful conference, VP conference with sir in Bhopal in 2024. That is the time I learned so many things from him. He has been offering free medico-legal consultation. People do medico-legal consultation as part of their, professional this thing. But Dr. Ajay Mane will give you medico-legal advice whenever you are in problem, very specifically, very nicely. And he's just one call away. So we appreciate your work done in Foxy, Mane sir.
Thank you.
Yes, your very big heart and your enthusiasm, which is always visible to all of us. And I have always repeated AMOGS, AMOGS and Maharashtra are my own. It is like my home state.
Yes, it is your home. It is your home. माइका बोल सकते हैं आप इसको. रंजीत भाई तकलीफ मत देना हमारे बहन जी.
नहीं सर बिल्कुल सर. Sure sir. सही बोला आपने सर.
So now I have the pleasant duty of introducing the remaining 14 societies of Maharashtra. We had Dr. Vishal. We had come till Nashik. So now we introduce Navi Mumbai OBGY Society. We thank President Dr. Bindu K.S. Madam and Secretary Dr. Vishwas Parulkar. Osmanabad OBGY Society, President Dr. Adinath Rajguru and Secretary Dr. Ismail Mullah. Dr. Ismail is with us from the beginning of the program. Palghar OBGY Society, headed by President Dr. Rajendra Chauhan sir and Secretary Dr. Rajendra Tiwari. Pandharpur OBGY Society, headed by President Dr. Sudesh Doshi and Secretary Dr. Sachin Pawar. Parbhani OBGY Society headed by President Dr. Jayashree Yadav and Secretary Dr. Megha Jadhav. Pune OBGY Society headed by President Dr. Uma Wankhede Madam and Secretary Dr. Charulata Bapai Ma'am, who was also the chairperson of the Breast Committee of FOGSI. Pusad OBGY Society headed by President Dr. Pranita Revanwar Ma'am and Secretary Dr. Meera Dange. We congratulate Dr. Meera Dange for doing some amazing yoga feats in the recently concluded AMOGS yoga competition. Satara OBGY Society headed by President Dr. Sanjay Jadhav and Secretary Dr. Surya Kumar Khandare. Sevagram OBGY Society headed by President Dr. Shuchi Jain and Secretary Dr. Shivani Yadav. Sindhu Durg Nagari OBGY Society headed by President Dr. Sanjay Nigudkar and Secretary Dr. Shamita Birmole. Solapur OBGY Society President Dr. Vijay Pawar and Secretary Dr. Pragati Vitthal Sathe. Thane OBGY Society President Dr. Rekha Thote and Secretary my dear friend Dr. Nupur Mittal. Udgir OBGY Society President Dr. Jagdish Yerolkar and Secretary Dr. Masarat Attar. Last but not least, Yavatmal OBGY Society headed by President Dr. Swati Motewar and Secretary Dr. Kiran Dhurve. So we thank all our 44 AMOG societies for collaborating with us today, for being with us throughout the program, for enjoying the academics. And now I hand over the session to Dr. Virul and Dr. Purva to start the panel discussion.
Good evening, everyone. Now we are at the last part of our session, which is panel discussion on the topic Dilemmas and Ovulation Induction in IUI Cycle. For that, we have moderator Dr. Tarini Taneja ma'am and Monica ma'am. Ma'am is the whole soul of our synergy. And we have esteemed panelists with us. First, we have Dr. Aishwarya Bidkar ma'am. Ma'am is Secretary at Daily Obstetric Society. Welcome you, ma'am. Next, we have Dr. Aparna Raul ma'am. Ma'am is Fertility Specialist, Aurangabad. We welcome you, ma'am. Next, we have Dr. Arushi Kajave ma'am. Ma'am is Secretary at Ichil Karanji Obstetric Society. We welcome you, ma'am. Next, we have Dr. Ismail Kasam sir. Sir is Secretary at Osmanabad Obstetric Society. Welcome you, sir. Next, we have Dr. Kiran Dhurve ma'am. Ma'am is Secretary at Yavatmal Obstetric Society. We welcome you, ma'am. Next, we have Dr. Manjushri Murli ma'am. Ma'am is Fertility Specialist, Amravati. We welcome you, ma'am. Next, we have Dr. Meera Dange ma'am. Ma'am is Secretary at Pusad Obstetric Society. We welcome you, ma'am. Next, we have Dr. Meghna Agarwal ma'am. Ma'am is Secretary at Nagpur Obstetric Society. We welcome you, ma'am. Next, we have Nisha Hilangle ma'am. Ma'am is Secretary Miraj Obstetric Society. We welcome you, ma'am. Next, we have Dr. Preeti Vyas ma'am. Ma'am is Treasurer Mumbai Isopar. We welcome you, ma'am. Next, we have Dr. Sangeeta Tajpuria ma'am. Ma'am is President Nagpur Obstetric Society. We welcome you, ma'am. Next, we have Dr. Saili ma'am. Ma'am is Secretary at Amravati Obstetric Society. We welcome you, ma'am. Next, we have Dr. Shivani Yadav ma'am. Ma'am is Secretary Sevagram Obstetric Society. We welcome you, ma'am. Next, we have Dr. Suchi Jain ma'am. Ma'am is Professor HOD at Sevagram Varda. We welcome you, ma'am. Next, we have Dr. Vishal Patil sir. Sir is Secretary Duli Obstetric Society. We welcome you, sir. Now I hand over sessions to moderator for the wonderful panel discussion. Thank you.
Thank you so much. After listening to such enlightening talks, there is very little to talk in the panel. It is going to be a general discussion. We have keen IVF practitioners, we have general OBGY specialists. So we will keep it very simple and allow me to share my screen. Yes. Excuse me for the delay. Again, the same problem has happened.
Visible, ma'am.
Yeah. Okay. Sorry for the delay. So we come to troubleshooting in ovulation induction. I would encourage everyone to join in. There is no specific question for any particular panelist, and all of you are experts. We will just try to see wherever we have doubt and how we can solve these issues through evidence-based practice. The first, we have already discussed the cases we are going to share. The first case is going to be, I thank the panelists for being there with us till the end of the program. So this is a relatively young couple. Both the husband and wife are 32 years old. They are trying for a pregnancy since the last 2 years. The husband's semen parameters are normal. The woman has got a normal general examination, normal gynec examination, normal pelvic ultrasound, as well as hormonal tests. Now, how do you define such a couple? And can you say whether IUI is indicated for them? How will you plan their treatment? Trying for
Hi, Monica. Aparna here. I
Hi.
congratulate you for a very nice program, very informative, and this is one of the finest webinars I have attended in recent, and we hope to see you on a bigger platform soon. So I would like to answer this question. They fit into the category of unexplained infertility, but I think their tubal patency has not been done. So I would like to go for first tubal testing and then for IUI.
Yeah. So Aparna, how will you define unexplained infertility? I don't want a textbook definition, but a particular patient who comes to you for the benefit of our audience and postgraduates. What exactly is unexplained infertility?
See, if a couple is not able to conceive with 1 year of unprotected intercourse when the female is less than 30 years, or with 6 months of trying and she is more than 35 years, and then you go for investigation and then you don't find an obvious cause, male is normal, she is ovulating, like everything, and tubes are normal, then it goes under unexplained infertility.
Yeah, so if you do not have any documented cause of infertility in your preliminary or basic investigations, you label that couple as unexplained infertility. How much percentage of the total practice in your practice or in anybody else's practice does unexplained infertility form?
Right now, I think out of infertility cases you are asking?
Yes, out of total infertility patients, how many are unexplained?
Almost 30% in my practice, actually. I don't know the textbook defining what trials are saying, but in my patients, almost 30% are there in which I cannot find any cause, but still they are not able to conceive.
So, what do you think? IUIs are worthwhile in
Yeah,
in our
definitely. If you go for IUI with stimulation, especially with gonadotropins, as we heard from the previous lectures also, ovulation induction with gonadotropins and IUI, then it definitely increases the chances of conception in unexplained infertility, because we don't know on a molecular level, on a personal level, what is going wrong. So definitely we are sure that we have put in a sample which is going to work.
So, in a case of unexplained infertility, would you try in a 32 years old a cycle of CC or letrozole, or would you straight away go to a combination of oral ovulagens plus gonadotropins?
If she's coming for the first time, then I give her a trial of latrose. And then if I don't like, if one or two, if her AMH is good, because I don't want to keep trying with a poor ovarian reserve. We want to do best possible with whatever oocytes we have. So if she has a normal AMH, we go for latrose 1 or 2 cycles, and then we add on gonadotropins, and then I advise her IUIs. Right now, as sir rightly said, patients don't stay if you keep on trying like older days. They kept on coming to you with 1 cycle, 2 cycle. They look for another gynec if you don't. So I explain to them whatever is my plan. and then I do as fast as possible. I give whatever I can give them best chances of conception with whatever plan I have for them. It's an individualized approach actually.
Yes, so
For
now
me,
this has changed, as Aparna rightly said. Patients change doctors at the drop of a hat. So most of them do Insta shopping for gynecologists, for IVF specialists. So there are so many reels and so many things are projected on Instagram and Facebook that sometimes patient loses the distinction between virtual and reality. So Dr. Preeti, you are there and you are paying a lot of attention to the program, I know. Dr. Preeti
Yeah, I was there. It was a fantastic program, Dr. Monica. I think it was really good. Yeah.
Thank you so much. So that is the aim of Synergy. Actually, the prime focus is academics, but we have to involve societies because it is a Foxy initiative. So we want to involve Foxy societies, and I give complete 100% marks to all my president secretaries. Whichever state I have done Synergy in, the presidents and secretaries have given their total commitment to me. I've never had a no. Very, very cooperative, very eager to pick up the calls, nice to talk to, and helpful. So I give my complete thanks to them. And I also request for support and vote for my dear friend Preeti for her
Thank you, Monica. Yeah.
for Dr. Shinde. Sharad Shinde is also contesting. So I seek blessings not only for myself but both my friends. So now tell me, Preeti, would you do a tubal testing in a woman who is very young? Not this couple. She's just 28. She's just married for a year. She's come to you for infertility workup. You see a beautiful TVS in mid-cycle. You see a developing follicle and no sign of PID, even remotely. Would you do a tubal testing in that couple?
I don't think so. I think first thing I would do is just reassure the couple that things are basically looking fine and normal. Find out if they are really been trying. A lot of times, patients come to you saying, we've been trying for 1 year and they've not really been trying. They've been missing out the fertile days. They've been missing out on the good ways of having sex. A lot of times we'll end up having couples who are not even sexually active the right way, or they are more like weekend sex with these corporate jobs that we have in Mumbai. They hardly get any time for each other. So a lot of times these are the social issues that you need to first address to figure out whether there was something really wrong there. And if a patient is young, has hardly been trying, married for only a year, doesn't look like any obvious cause which is really hampering her fertility, then I don't think I would jump and immediately tell her to do a tubal testing for the thing. Maybe what we would do is counsel them on the fertile days. If they've already been trying that for quite a few months, then maybe then we would think of suggesting to them whether they want to do an ovulation induction before all the, and of course all that would be after the basic investigations are done, like the basics would be in the form of a thyroid, a prolactin, maybe an AMH if it is required. We see the antral follicle count when we do the sono. So first start with basics, rather than jumping for investigations on the first go.
So that's a very clear message given by both the panel experts. Dr. Aparna has told us categorically that unexplained infertility can only be labeled once you have tested the tubes, because you're going to label it unexplained and then treat her as unexplained. Having said that, an unexplained infertility after 3 to 4 cycles of IUI can go for IVF. In fact, there's a fast track trial which says one well done cycle of IVF is better than 3 to 4 cycles of failed IUI in unexplained infertility, because for all you know, the fertilization may not be happening in such patients. Though that interaction at the level of gametes can only be studied in a lab. You have failed IVF, you have to do ICSI for such a couple sometimes. So, and Dr. Preeti has given a very important message that when the patient is, recently married, young, you have the benefit and advantage of time, and you feel on a TVS and by history that everything is normal. The uterus is looking normal. The tubes, they don't show any obvious pathology on a good TVS, and the patient has no history of any pelvic infection. You can easily forego the tubal testing for some time. Thank you so much. So now we come to the pregnancy rates. Of course, we have listened to a lot of good scientific studies by Dr. Pratik and later by Dr. Jatin that stimulation increases the pregnancy rates. And vis-a-vis intercourse, naturally you have better pregnancy rates with IUI, and those pregnancy rates can be further multiplied when you use your ovulagens and gonadotropins effectively. And there is little evidence to assess IUI in unstimulated cycles because the pregnancy rate will be so low that you will basically be wasting a cycle and you will risk losing the patient also. So, in general, the indications of IUI, which are the maximum people you recommend IUI? Dr. Kiran, Rama Madam is also there with us from Ajmer. Namaskar, Madam. So, would you like to tell us what are the indications of IUI in your clinical practice? Dr. Ismail, please.
Namaskar, ma'am.
Yeah. Anybody can take the question. What are the commonest indications where you do IUI in your clinical practice in the
I
state?
think can I take
My
that
sperm
question?
quality is so compromised.
Yes, yes.
I
In
think
case
Dr.
of
Rama is trying to talk.
Rama,
Yes.
please, बताइए.
Ma'am, when the sperm quality is compromised and patient is of borderline age, now tried so many times, tubes are patent, but still not conceiving. Sometimes PCOD is also there. So ovulation is delayed. So we can program ovulation and planned intercourse can help them.
Yeah. So one of the most common indications of IUI, as rightly stated by Aura panel experts, is unexplained infertility, mild male factor, like Rama Madam has said, mild endometriosis. Now, there are certain indications like non-medical indications for IUI, which are very common in the modern world. So, Dr. Sayali, you are there with us, and Dr. Ismail. Do you get patients where there is no medical indication for IUI, but you still have to do IUI for some non-medical indication?
I think we do land up having that a lot in metros where we have single women coming to us wanting a pregnancy. We even have same-sex partners coming to us wishing for pregnancy. I mean, this is the newer indications, that we are seeing in our metros where we do have these kind of, and then there are certain times when you also have people who are not able to have intercourse because of some pelvic dysfunction or because of erectile dysfunction, and these are the ones where yes, you will require to do an IUI.
Yeah, and the last one is jobs. Spouse has got a job either in the defense,
Outside, yeah.
outside, merchant navy, living abroad. So that person can just freeze the semen sample and that can be used for IUI, provided the count and everything is good. So these are the
patient we had who had vaginismus.
Yes.
So that patient we did a IUI.
Yes, bilkul. Sayali is absolutely right that sometimes there is severe pelvic pain, vaginismus. Those cases, of course, you can deal with the vaginismus, treat it, but you can also do an IUI in such cases. Now, what are the contraindications when you do not do an IUI? So don't just you tell the patient not to do the IUI. What are the contraindications?
If there are bilateral tubal blocks, in that case, we don't advise the patient to go for IUI. And in case of male infertility, if there is severe abnormality related to semen analysis, the semen count is less than 5 million or 10 million.
Yeah, severe male infertility, teratozoospermia, oligoteratozoospermia, Oates syndrome, and active pelvic infection. Suppose you find an active pelvic infection, you don't do IUI. If you have got documented proof of bilateral tubal block, you don't do IUI. So these are the indications for IUI, the commonest ones in clinical practice. These are the contraindications or the exclusion criteria. We just came to know the total motile sperm count, how much is needed for a good IUI cycle, the minimum being 1 million after post-wash. So now after doing that unexplained infertility, we have just skimmed through it. I know I have not gone through the details, but that was the purpose of the panel. We come to another common case scenario of a PMOS patient. Now, this is a typical PMOS patient. She's 28 years old. Thankfully, she got married at the right time or had a partner at the age of 25, but her BMI is 28. She's overweight. Her HSG and semen analysis of her partner are normal. And this woman, because she has read in a lot of Google sites and consults a lot of doctors online, she has tried ovulation induction with letrozole on her own several cycles. And then finally, she goes to a gynec for IUI. So there is one gynecologist, Dr. Kiran Dhurve, who wants to proceed with IUI straight away. And there's another gynecologist, Dr. Sayali, who wants to wait for some time and address her health holistically. What do you prefer? What are the advantages, pros and cons of both? Should you straight away treat her, start treating her, or should you counsel her to wait for some time, try to improve her lifestyle and risk losing the patient?
Yes, ma'am. Considering her from IT profession and considering her weight part that she falls under overweight category, I would like to go for lifestyle modification, which includes dietary modification and weight reduction and exercises. And after that, I mean, if that factors works well with her, then I would like to think for letrozole cycle and for IUI to induce her and to go for IUI later on.
Yes, but having said that, if she insists for IUI and she is basically there only for a couple of cycles, then with all precautions, you can start your metabolic measures. You can start a drug, inositol also, metformin, and start your IUI also. If a patient doesn't want to wait for 2-3 cycles, then this is not the era where you can, force her. You can just concurrently start lifestyle modifications and be very realistic. All your goals should be smart. So, Dr. Ismail, can you tell us, according in PMOS now, in PMOS, if you want to have improvement in the patient's physical parameters, reproductive function parameters, what are the SMART goals? Ismail sir, please unmute.
Yes.
Yes.
Hello. Yes, ma'am.
Yes.
Am I audible?
Yes, you are.
Yes. The weight reduction is a lifestyle modification is a cornerstone of this patient. Weight reduction is a necessary for such patients. Then healthy behavioral strategy is necessary. The diet and 30% calorie deficit diet is necessary, and exercise.
Yes, very true. And you don't have to stress out the patient to lose 10 or 15 kgs or 8 kgs in 2-3 months.
No, step by step.
Just tell her to reduce 5 to 10% of the body weight.
Yes.
So suppose it is a 70 kg woman, she just tell her to reduce about 3.5 kg, 5 kg. So the goal should be specific. You should tell specific figure. It should be measurable. You should be able to see the reduction in the inch loss or the waist circumference or in the weight. Achievable. That woman or that lady should be able to achieve that goal with that particular set of exercises she is doing. And the exercise has to be at least 30 to 40 minutes per day for at least 5 to 6 days. Realistic. So the goals have to be something which she can do. If it is a semi-urban or a rural area woman, you can't expect her to go to the gym. So you have to encourage her to just walk on the terrace or maybe do some yoga. There is some wonderful online yoga also. And basic is to cut down on the calories. Rama madam, you wanted to say something?
Yes, ma'am, I had an endocrinologist topic discussion on PCOS. So they said ki don't leave the patient for weight reduction unaided. You should add metformin or drugs like that because it's very difficult to lose weight with PCOS just by saying exercise and diets. You
Yes.
must add metformin type of drugs so that they can be beneficial.
So I'm totally in favor of metformin, and this is not the new kid on the block. This is an old kid on the block, and we have got a few. Actually this is one of the adjuvants of choice. Now that brings us to the next question. I think I'll skip to this slide. Can my panelists tell me that out of all the adjuvant drugs for PMOS, in IUI or infertility patients who is specifically wanting a baby, what do you prefer? You prefer metformin, or you prefer inositols, or you prefer a combination, or you do not prefer anything?
I
All of
think
you.
metformin is a no-brainer. We definitely want a metformin to be added. We do encourage them to lose weight, and while they are on metformin, if spontaneous ovulation doesn't start, then of course we need to add something to make them ovulate. So an ovulation induction with metformin will give us a little better this thing, where we do a combination basically.
Yes. And any experience with inositol? Anyone? Rama Madam, Sayali, Kiran?
I'm
I think
used
we
to
all
see
have.
inositol, but it is not recommended in textbooks. So, or we used to use it with combination of drugs, so we cannot say ki it is only because of my inositol it is help.
No, they both work differently. Inositol and metformin, their mechanism of actions are different.
Yes.
So
Yes.
yeah,
I
you
wanted that. I wanted that. Please elaborate. Aparna is
uh,
there? Yeah.
their mechanism of action is different. Inositol is acts differently, and this metformin acts differently. There is decrease in insulin resistance, everything with metformin, while inositol acts by the different pathways. So they both are actually beneficial. Even if you use a combination, it works well. Though inositol has not been researched, but there are not a lot of trials, but I'm talking of practical experience.
Yes. So can you see my screen, or the screen has gone?
It's
Ma'am, one question I would like to ask actually. There
Yeah.
are some combination related to melatonin also in the form of tablets. So is it really helpful?
melatonin combinations are not approved by FDA, so they have removed, like recently, they have removed melatonin from these combinations. They are giving now without combinations, and melatonin is a stress buster, and it helps to like normalize sleep and all. So you now the combinations are not available, ma'am. They
And
have
what about berberine? Are you using berberine, Aparna?
Berberine I am using, but it like I am using that for mainly adolescent PCOS, in which like they don't tolerate metformin or inositol is not proven, but berberine works very well for adolescent PCOS.
I'm also using a combination, like somebody mentioned, the mode of action. I'm using a combination of metformin and inositol in some of my patients, especially the younger patients, because metformin will work at the gluconeogenesis and glycogenolysis mechanism, and inositol work at the membrane level through the
Right.
ion fluxes. So the combination of these two is sometimes better, especially in the younger age group and adolescent PCO. But in fertility practice, I think a plain metformin is also good. So I think it's 8:30, and you want to continue? My slide share stopped automatically. You want to continue, or do we wind up after the PCO patient? I wanted to discuss a few slides of the gonadotropin stimulation. Yeah, are my slides visible now?
Yes.
Yes. Okay, so let us proceed. So metformin is definitely a big yes. Now, there is Dr. Ismail. He's got a very good fertility practice, gynec practice, and he is fond of doing laparoscopic ovarian drilling. So, Dr. Ismail, tell me, should you do in the current scenario where gonadotropin therapy is encouraged with safety net, would you still continue with LOD, ovarian drilling? In which cases would you do? In which cases you will not do, or you will not do at all? Please tell us something about LOD.
In this case, actually, she's failed several letrozole cycles. So gonadotropin IUI is a reasonable next step. LOD is mainly reserved for a clomiphene letrozole resistant woman, where gonadotropins are not feasible or repeated monitoring is difficult. In that case, I will do LOD, ma'am.
So if you're putting a scope inside for any other indication in that patient, if you do a few selected punctures, that rule of 4, golden rule of 4, 4 punctures in each ovary, 4 mm, and minimum energy, a pure cutting current, it actually is not bad. The advantage is a lower cumulative cost of treatment. And I personally have a patient who is wife of my CCTV person in the hospital. I had done 2 IVF cycles for her, severe PMOS, and 4 cycles of IUI. Then she was not able to conceive. She reduced her weight also. I just did a laparoscopy with LOD with her, with lot of counseling, and she conceived after LOD. She conceived in the second IUI cycle, and now she is 24 weeks pregnant. So sometimes it works. It may be just a by chance case, but LOD cannot be totally done away with. I don't agree with papers or proponents who say don't do LOD at all. If you are having such a resistant case with large ovaries, thick cortex, and no other reason, and your gonadotropins are not working, you as such are putting a scope inside, and you've got good instrumentation, you can, easily do LOD very carefully and get,
I
optimal.
read somewhere that patients with high LH they get benefit more from surgical procedures, while patients with FSH and LH normal ratio with PCOD they go well for with medical management.
Yes. And nowadays, there are so many variations of PMOS. I had a typical patient. Of course, she was a young woman who was not wanting fertility. And this lady, nowadays, we are getting typically ovaries which are long. They are shaped like a sausage. All the follicles are arranged peripherally. And the volume is not more than 10 ml. The volume of the ovary is something between 6 to 8 ml. She has got irregular cycles and she has got biochemical features positive. So sometimes the ultrasound features of a polycystic ovary does not correspond to the textbook picture. So this is in the Rotterdam's criteria you have to keep in mind. Now, such a patient, she has failed 2 cycles of letrozoles. And how much is the maximum dose of letrozole you go to in such a patient? Her AMH is 8. Her BMI is 28. She has lost 3 kg of weight. And now you have put her on letrozole gonadotropin cycle. How do you go about it? What dose of letrozole? When to start gonadotropin? How much is the dose of gonadotropin? Anybody? Kiran? Dr. Sayali? Letrozole first. Let us talk about the letrozole dose. What day of cycle will you start letrozole? Will you use 2.5, 5 or 7.5? Then I'll tell you my story.
Usually start with the lowest dose, 2.5.
2.5
If the
sometimes,
cycles,
Dr. Sayali, it will not work with PMOS. You will get, you might try once, but then if the patient is there only with you for 3 cycles or 2 cycles, you might waste. In PMOS, I feel it's a better idea if you start with a letrozole dose of 5 mg.
2.5 BD or 5 mg. There are various ways of giving it actually. Or you can give the whole dose together 7.5. They including those first day 1 tablet, second day 2 tablets. It all comes to the same. But 2.5 BD or 5 mg once a day works better.
Yes. And Dr. Aparna, I got a patient referred from Raipur by my friend. She had stimulated the patient with oral ovulation and referred to me for IUI. So she was wife of anesthetist, and I saw both of them. She had about 2 follicles growing when she came to me. I did one good cycle. There was a mild male factor also. I did a single cycle of IUI. She conceived.
Very
And
nice.
she conceived, the pregnancy went on beautifully, everything. Now, her dose of letrozole was 7.5 mg daily. From day 2 to day 6 of cycle, I immediately rang up my friend. I said, for the first time in my life, I have seen 7.5 mg. This was a couple of years back. She said, Monica, I'm using 7.5 mg since many years, and this is just not one patient, many patients have conceived. Since then, Dr. Aparna, I'm using 7.5 mg, 3 tablets of letrozole daily from day 2 or day 3 for 5 days, and I'm getting a very good response. The requirement of gonadotropin also comes down. It's
How many follicles you get? Multi follicles?
two, maximum 3, but the third one doesn't grow without gonadotropin. Suppose you are
Okay,
getting
I'm
7.5 yeah.
after listening to you, I will definitely try my next patient and I'll talk to you what result I get.
Yes. So my practice with letrozole changed after this patient conceived, and I talked to my, ART practitioner friend, and she was very clear about her this thing, and I did this. Now I'm doing a small study on 7.5 mg of letrozole in PMOS patient. Let me see how many patients I can gather before the next conference, and then I'll share with you. So, this is about gonadotropins. Now, gonadotropins. Virul, your patient. Virul, are you there? I think Virul is busy with her clinic is getting. Nisha, madam, are you there? Dr. Nisha? Okay. So,
Yes, ma'am.
Dr. Nisha, would you like to comment on this patient? She has not responded to letrozole, and now you want to start gonadotropin.
Ma'am, as she has LH, high LH, so I will prefer FSH. Yes. From days 8, 9, 10.
Okay, you will put her on FSH. What dose? The day you stop letrozole or concurrently with
Next,
letrozole?
next day 75.
75. Okay, 75. And would you use the same dose? How often will you call her for monitoring? How much dose you will increase?
Not increase. I will give 3 doses of 75 and call her alternate day for monitoring.
Okay, so there used to be, I also use alternate days. Sometimes I use daily gonadotropin, but there are certain practitioners who feel that giving daily gonadotropin is more effective as compared to giving alternate day. Again, it's a controversial statement. I also use very minimal amount of gonadotropins in my PMOs. I'm getting good results. So we are open to discussion. Trigger, what about trigger in such a patient? Dr. Preeti, how will you trigger your PMOS patient who you have given letrozole plus gonadotropin?
So I think the first thing is I would probably, when I start my gonadotropin itself, I would be a little this thing where I would like to see the antral follicle count and then decide whether I want to start the gonadotropin also a little earlier or a little later, rather than putting them on day 8, 9, 10. I usually prefer to start my gonadotrophins a little earlier where there is a overlap between the letrozole and the gonadotropin, and then the trigger is given when the follicle is looking nice and mature, at around 19 to 20 when you can actually make out that the follicle is looking mature, it's looking nice and thinned out. Whether we'll end up doing a Doppler at all or not, but we do land up looking at the quality of the follicle before giving the trigger. Usually in my practice, I do use more of HCG triggers, but we do use the recombinant HCG also, and it definitely does give good results.
So we are using
I
the
think
same trigger basically. Dr. Pratik Tambe said a trigger of 10,000 international unit. I've been using 5,000 international unit for now close to 28 years. So I'm happy with that. But there is sometimes, my IUI results are really, really good. Because first of all, I get lots of patients for IUI. Patients, because IVF centers are usually do not take IUI that seriously, and they
yes,
very low threshold for conversion to IVF. So even if the
very
patient,
good. Yeah, that is true. Yes.
so they convert to IVF, like there's a particular commercial chain of IVF centers, the largest chain in India. So you go to any of their top running centers, they do not entertain IUI. So any patient comes to them, oh, IVF will give you, 40% result, 50%. People are even claiming 80%. So whatever they claim, you don't know, but these IUI patients are the ones which you can, call and treat very nicely, filter them, give them good evidence-based treatment. I assure you, this 8 to 10% result of IUI is only in textbooks. With proper selection of letrozole, with the proper, ultrasound monitoring, good trigger, and good semen preparation.
Good support and a
Support.
good post ovulation support.
No, Dr. Preeti, here I will differ. In IUI, if the follicle has ruptured, the corpus luteum is so good.
No. So there are times when people land up doing a trigger with the decapeptyl and all the triprol and this thing, and what happens is a lot of times instead of doing, I mean, you are supposed to do that purely for IVF cycles because the luteolysis is going to just take away all the progesterone. But I've seen that happening even in IUI cycles where, people end up giving that. And then with that, if there is not good progesterone support, this is as good as a gone cycle.
No, I think I will get back to this. We will keep the group active and I will go through all the papers where agonist trigger has been given for IUI. I don't think it's very common. But if you have a good HCG trigger in IUI, as such also you have got a support, HCG support. You have got a corpus luteum. So in IUI cycle, you can even get away with 1 HS vaginal progesterone. And there are some patients who have not used luteal support at all and they come with a pregnancy.
No, I'm talking about where they've landed up getting a trigger with a
Yeah.
decapeptyl. Yeah, not
Absolutely.
for the HCG,
Yes.
not for HCG.
I think
Yeah.
we'll just go through the papers where agonist trigger was given for IUI and see how many cases are being done.
अरे वो कचरा निकाल लो, भेजा है मैंने.
So that finishes the PMOS patient, and now we are
Somehow we are not able to see your screen, huh, Monica?
again.
Black color. I don't know whether I'm the only one not able to see it.
Okay, the slides are not visible now.
Not visible.
No.
Not visible.
No, not visible.
I don't know what's happening. 1 sec. No, now is it visible?
Yes,
Nimisha?
we can see now. Yeah.
Thank you. Okay.
Yes.
So that brings us to the end of the second case. This is again a protocol somebody has given, 2.5 mg of letrozole for 5 days, followed by gonadotropin, like Dr. Kiran just shared with us. The trigger for ovulation, we have discussed the, recombinant versus urinary, the doses we use. Now, the last question. In this PMOS patient with your gonadotropin and letrozole protocol, you ultimately land up having 4 to 5 cycles which are mature. What are the options you have? What all can you do in order to keep that cycle going? And what are the options you have? Dr. Aparna? Dr. Aparna, are you there? Okay. Dr. Ramam, Dr. Kiran? You have formed supernuclear follicles. You have formed 4 to 5 follicles in your PMOS patient, which are mature.
If patient is willing, we can convert. But if patient is not willing, then we have to look for the blood supply of the other follicles also. If we are supposed to get 2-3 follicles, we can continue. And if they are more than that, we can abort the cycle.
Aborting the cycle.
We will have to counsel the patient about the risk of multiple pregnancies and the risk of a mild OHSS that may end up happening if she gets pregnant in the same cycle. So that counseling would be very important because she needs to understand the implications of both. Sometimes patients are more than happy having twins, but we do need to counsel them that there are more than 4 follicles and what if she ends up having even a triplet or something. So those things have to be definitely discussed. You need to spend a good 20-30 minutes with this patient and discuss before giving them the choice of going ahead with the cycle, aborting the cycle, or converting it to IVF.
So converting is actually difficult, though it happens. your patients can convert to IVF, which would be the most sensible thing to do. But otherwise, you can also, does anybody have experience about aspirating the follicles and then continuing with the IUI? I personally have never done it.
No, I don't think
No,
we've done that. No.
Okay.
we have not done
I
that.
have
I
managed
have
to convert
aborted a
the
cycle because
Yeah.
patient was not ready to convert in that, but not that.
Okay,
So
yes.
typically what I tell my patients is तुम्हारा IVF में हो रहा है और वो भी सस्ते में हो रहा है, कर लो.
Yes.
Because then they have not spent so much money on the injections actually.
So if you
So
calculate, by the time the patient is having 14 to 15 follicle or 12 to 13 4 follicles or 5 follicles, you just have to introduce an ANTAC. You have to
ANTAC.
ANTAC for 5 to 7 days. The follicles will grow with minimum dose of gonadotropin. Do the pickup, do the transfer. I think that can be done at very cost-effective, rates, as Dr. Preeti has said. But then everything depends upon your counseling. And the last resort is not to trigger, not to give anything. Just follow up the patient, cancel the cycle, and advise abstinence because she can still land up with a multiple gestation. So this is all about the counseling, cancellation, conversion. Of course, like hormonal monitoring is not done. Like I totally agree with Dr. Jatin Shah that we are testing very less the hormones nowadays. Most of the monitoring is by ultrasound, which is more cost effective, and you grow in skill. So the last case is endometrioma of the ovary. This is the patient, and her tubes are patent. So as soon as the patient gets an endometrioma in the ovary, she automatically goes to ASRM stage 3. In ASRM stage 3, 1 and 2 you can do IUI, especially with patent tubes. Has anyone done IUI with chocolate cyst with patent tubes and got results?
Not done.
So I will tell you again, I had a stage 3 endometriosis. I had done laparoscopy for her because that time, it was more liberal laparoscopy. Now, after so many years of studying endometriosis, we know that one good surgery, primary surgery, should be the best one for endometriosis patient. But I got a patient with severe frozen pelvis, but her tubes were patent. And I gave that time we used to give Leupride depot, Leuprorin depot, 3.75 milligram. I gave her the first dose of that shot of that, and she went home and she conceived the next cycle. So this time, sometimes what happens is like in genital tuberculosis, the internal tubal microvilli architecture is disturbed because of the mycobacteria. In endometriosis, the tubal villi damage is not that severe. So sometimes in patent tubes with endometriosis, you can get a pregnancy even in stage 2, stage 3. And these patients,
Great.
if the surgery has been done well, the AMH does not fall that much. And Dr. Jatin Shah has given again a very important message for especially cases where you're converting IUI to IVF or going from IUI to IVF in a particular patient who stays with you. Remember to repeat the AMH. Any AMH value which you do should be repeated in the next 3 to 6 months. Never rely on that AMH value with which the patient comes to you a year earlier. So that brings us to the end of our IUI cases. We have done with unexplained infertility, we have done PMOS, and we've also dealt with a case of endometriosis. Having said that, stage 1 and stage 2 endometriosis, please, these are candidates for IUI. So never give away the opportunity of doing an IUI for them, because with patent tubes and stage 1, stage 2 endometriosis, you can easily achieve a pregnancy with IUI provided you stimulate her and you follow her up well. The factors affecting IUI success rates have been dealt with in both the lectures. We know important is female age, AMH, semen parameters are very important, tubal patency or timing. Has anyone done IUI with single block tube? What is your experience with single block tube?
नहीं, हम लोग किया तो है, पर वो उसमें उसी साइड में ओव्यूलेशन हो नहीं हो, बुक्स में तो लिखा है कि इधर से उधर ओवा भी पहुंच जाता। बट रिजल्ट तो अगर उस साइड में नहीं मिला तब नहीं, अगर ओव्यूलेशन उस साइड में नहीं हो रहा तो प्रेग्नेंट तो नहीं हो पाएगा.
Yes, madam. So what I did was in one of the ASHRAE conferences many years back, I was sitting with Dr. Chaitanya Nagori sir, who has experience of doing 10,000 IUI cases. I got hold of sir. I said, "Ki sir, what to do about single block tubes?" He said, "Do not tell no, do not refuse an IUI in such a patient." And he was also of the opinion you can have contralateral migration of the oocyte, but I've never got a pregnancy in a patient where the ovulation was on the block. So I think Rama ma'am, you are correct. If you've got a single tube patent, it is better to do IUI in a cycle where the ipsilateral oocyte is available. So thank you so much. We know that he who studies medicine without books is sailing an uncharted sea. But he who studies medicine without patients does not go to sea at all. So we have to keep doing our cases, keep improving as we do our IUI cases, and ultimately improve our skill in IVF cases. We know after doing 28 years of ART practice, when I listen to Jatin sir, I feel that I know nothing. So today only I have listed down so many things. I have to read the amount of papers.
मैम वो आपको शेयर करनी रहेंगी उनकी स्लाइड्स. मेरे पास कोई ना कोई आ गया था तो मैं पूरा सुन नहीं पाई.
No, madam, all these 2 lectures are recorded on YouTube. I will put the link of the YouTube in the WhatsApp group in 2 days.
Yes.
And you can watch
Thank
it.
you.
So
Thank you, ma'am.
with this, we come to the end of our panel. Thank you all for staying with us till 9 o'clock at night. It is exactly 4 hours since we started our webinar. And thank you to our support
Yes,
team,
ma'am.
my coordinators. Thank you, Dr. Vishal and Team Intas. And again, requesting humbly for your vote and support for myself, Dr. Preeti, and my friend, Dr. Sharad Shinde.
Thank you so much, Dr. Monica. I think it's a wonderful what you are doing, the synergy. You know, last year I was doing the precision series. आपका तभी भी चालू था synergy, and it's really nice. You know, I mean, you're really like dedicated, and yeah, all the best. And yeah, I would request everybody to support me also. I'm contesting this year for Safe Motherhood Committee, and I really look forward to working with Monica. साथ में काम करेंगे.
So this is
Yes,
just
ma'am. All the best to you, all of you.
Thank you. Thank you so much. And thank you, Maharashtra. Thank you, AMOX. Thank you, all presidents and secretaries, for being with us and for enjoying this program. And our next synergy is on 17th of July with Madhya Pradesh, my home state. And we will have some societies from Gujarat also. The topic will be announced soon. So stay with us and keep enjoying great academics. Thank you. Thank you so much.
Thank you.
Good
All
night.
the best.
Bye.
Thank you, madam. Thank you.
Good night. Good night. Bye.
Night.
Support team, please end the program.
Yes, sir.